presentation is by Team 3, that is KGMC Lucknow, being presented by Dr. Shrivats Mishra and Dr. Kartikeya Shukla. These
read out the CVs also. I just told my association with them.
Yes, ma'am. It is my privilege to introduce Dr. Devi Prasad Mohapatra, sir. He is my guide from JIPMER. Sir is professor in the Department of Plastic Surgery at JIPMER, project director for Smile Train Cleft project at JIPMER, also associate editor for Indian Journal of Cleft Lip, Palate and Craniofacial Anomalies. He is also editor for Journal of Educational Technology and Sciences. Sir, welcome you to today's session, sir. Our second panelist is Dr. Vinaykant Shankar, sir. He is a professor and HOD at Department of Plastic and Reconstructive Surgery at Tata Memorial Hospital, Mumbai. Sir's skills and proficiencies include onco reconstruction, free flaps, and breast oncoplasty. Sir has more than 40 publications in international and national journals. Sir is a principal investigator in many research projects on onco reconstruction. He has drafted protocols and guidelines for onco reconstruction in National Cancer Grid. Sir is reviewer for various journals in plastic surgery, has authored and edited many books and chapters in plastic surgery textbooks, and is also a faculty speaker and resource person in many national and international conferences. Sir has been Vice President for Breast Reconstruction and Aesthetic Surgery Association. Sir is General Secretary for Indian Society of Reconstructive Microsurgery, APSI Executive Committee member, and also has received multiple awards, including Excellence in Outstanding Contribution in Breast Onco Reconstruction in Apsicon 2022. Sir has also received Professor S.R. Singh Oration, K.R.K. Chaudhary Oration, and also International Glam Icon Award. Sir has been also has got Apsicon Visiting Professor Fellowship in Microsurgery in 2019 by Association of Plastic Surgeons of India and Apsicon Traveling Fellowship in Microsurgery. Sir has Army Endowment Best Report in 2012 and award and contribution in plastic surgery for Miss and Mrs. Global India Queen Awards and also Kamath Award 2005. Our third panelist is Dr. Sundaraj Ellur. He is a professor and head in the Department of Plastic Surgery at St. John's Medical College, Bangalore. And also Dr. Selva Sitaraman, sir, who is a senior consultant and head at Lineal's Global Health City in Chennai. Sir is a microsurgery instructor for EISE, trained in centers of excellence at Singapore, Taiwan, South Korea, and also UK. Recently, last year when Sushruta Film Festival was conducted, sir was the runner-up in 2023. Sir has Best Publication Award for APSI in 2014. Lead hand transplant team has led the hand transplant team and has been felicitated by Honorable Vice President. Sir is the founding trustee for Selva Shakti Trust, which helps the underprivileged. Sir's primary fields of interest are microsurgery, cancer reconstruction, diabetic foot, and lymphedema surgery. We welcome all of our panelists to today's session. Ma'am, over to you.
Yeah, I want to inform you the judges team, eminent judges from all over the country will be observing the program, and they will give the marks for various components. This is a competitive session. So the proceeding is first the PGs from KGMC, they present 10 minutes the case, and after that the panelists will discuss the case for each 10 minutes, and later the spotter, X-ray, all these components will be 10 minutes. So they give the diagnosis and relevant things, and discussion will go on. So at the end of the completing the session, each panelist will give the analysis of the performance of the PGs, and from their side anything to be contributed. Any unanswered questions also can be answered, and they will tell something, their opinion about the Plastiquest. So this is the program today. We'll start with the case presentation. And Likita, kindly take the roll call of all PG teams, of
yes,
whether they are present or not.
Yes, ma'am. I request all the teams to kindly give the roll call once. First is Madras Medical College.
Yes, ma'am. Present, ma'am.
Yes.
Yes, start your video. Yeah. Okay.
Jipmor
Be
Pondicherry.
ready for asking question when that session comes. Okay.
Yes, ma'am.
Yes,
Yeah.
present, ma'am.
KGMC Lucknow is already here, ma'am. Stanley Medical College, Chennai. Stanley Medical College, Chennai. Ma'am, I think they have not joined yet. AIMS, New Delhi.
Note down that.
Yes, ma'am.
Yeah.
Present, ma'am. Bangalore Medical College.
Present, ma'am.
CMC Vellore.
Here, ma'am. Here, ma'am. Present.
Safdarjung, New Delhi.
Present, ma'am.
RML, New Delhi.
Present, ma'am.
BJMC, Pune.
Put it in your
BJMC, Pune. Keelpok Medical College.
Yes, ma'am.
MAMC, New Delhi.
present, ma'am.
ESI, Faridabad. ESI, Faridabad. SRMC, Chennai. AIMS, Bhubaneswar.
Present, ma'am.
AIMS, Rishikesh. AIMS, Rishikesh. Okay. Ma'am, as of now, 4 teams are absent, but I think we'll start with the presentation. Lakshmi, ma'am.
You note down that they are absent and put it in the group. They should inform us when they report in
Yes.
the chat box. Okay. KGMC, please
Yes, ma'am.
start your case. All the best.
Thank you, ma'am. Good morning. Sorry. Good evening, all respected faculty members.
Make it full screen.
Ma'am, is it full screen now?
It is not full screen. Okay, go ahead.
Good evening, all my faculty members. I am presenting a case on topic carcinoma right lateral border of tongue. My patient is a 43-year-old male patient, a Hindu by religion, laborer by occupation, resident of Ayodhya. Chief complaint, he came with complaint of proliferative growth over right side of tongue since 6 months. Pain over growth since 5 months. This is the growth. Patient was history of presenting illness. Patient was apparently all right 6 months back when he sustained trauma to right side of tongue while chewing food due to tooth bite, and following which he developed an ulcerative lesion over right side of tongue, which was healed in 1 week. Later, he noticed a linear growth which healed over the healed region, which was sudden in onset. Over the healed region, which was sudden in onset, gradually increased in size from the size of grain to and attained a maximum size of growth in 4 months. Growth over right border of tongue is associated with mild to moderate degree of localized pain, which is of burning type over the affected area of the tongue. Pain is radiates to right temporal region. Pain aggravates when food comes in contact with growth and relieved on drinking cold liquids and on taking analgesics. Later, also associated with recurrent trauma, resulting in occasional blood staining and chewing and while cleaning tongue. History of drooling of saliva occasionally notices on awakening. History of disarticulation of speech. Patient took analgesics to relieve pain as advised by local practitioner. Patient was then consulted to a dental department where his edge biopsy was taken from the growth 2 months ago. Patient received 1 cycle of chemotherapy, following which the tongue growth and pain reduced to mild degree 1.5 months ago. Not associated with any other lesion in the oral cavity. No history of weight loss and decrease in appetite. No history of halitosis. No history of loosened tooth. No history of restriction of tongue movement. No history of difficulty on or pain on swallowing meal. No history of loss of touch, pain, pressure, temperature, taste sensation. No history of any white or red patch in mouth. No history of sleep disturbance. No history of difficulty opening mouth. No history of change in taste. No history of any neck swelling or other adjacent areas. No history suggestive of any distant metastasis. Example, any bony pain, cough, breathlessness, hemoptysis, jaundice, pain or lump in abdomen. No history of any white or red patch in mouth. No history of sleep disturbance or difficulty in opening mouth. Now, past history, patient is having history of hypothyroidism since 6 months, and patient is on tablet thyroxine 100 microgram OD. No past history of diabetes, hypertension, bronchial asthma, any allergy. There was history of silencer burn over the lateral aspect of left leg 20 years back, managed conservatively elsewhere. History of lower gum discharge 15 years ago, conservatively managed elsewhere. Personal history. Patient is a known BD smoker. Patient used to smoke 1 bundles of BD per day since 25 years. So it is equivalent to 25 pack years. And he stopped since 6 months. Patient is also a chronic gutka chewer once, frequency once in 2 to 3 days, and pan chewer once in 10 days. And last taken 6 months ago. Patient is a known alcoholic, 1/4 of indigenous alcohol intake daily, and stopped 6 months ago. Mixed diet, normal habit is normal bowel and bladder habit, no sleep disturbance. Family history, no such history of any oral cavity ulcer in the family. General examination. Patient was examined in a sitting position in a well-lit room, an elderly male with moderately built with a body mass index of 19.03. Patient is a conscious, cooperative, and oriented to time, place, and person. Pulse rate 68 beats per minute taken in the right radial artery. It is normovolumic, normotensive with no radial on radiofemoral delay. Blood pressure is 128 by 88 millimeter of mercury taken in the right arm in supine position by the auscultatory method. No pallor, icterus, clubbing or cyanosis or edema or any generalized lymphadenopathy present. Systemic examination, respiratory system is bilateral, air entry normal, cardiovascular system, S1, S2 normal, no murmur heard. Per abdomen, soft, non-tender, no organomegaly. CNS is conscious, oriented to time, place, and person. Now come back to local examination. On inspection, facial symmetry is normal, no deviation of angle of mouth, adequate mouth opening of 3 finger breadth, poor oral hygiene with stained tooth is there, loss of left first maxillary premolar. Buccal mucosa, retromolar trigon, floor of mouth, they all appears normal, and cranial nerve examination are within normal limit. Tongue is slightly deviated to right side on protrusion. There is no restriction in tongue movement. A single proliferative growth of size is 4.5 by 3.2 centimeter present over the right lateral border of tongue. Extent of growth is anterior border is 3.5 centimeter and the posterior border is 8.8 centimeter from the tip of tongue. Now dorsally it extends 2 centimeter lateral to the midline and ventrally extends 1.2 centimeter lateral to midline. Growth is not crossing the midline and is not involving the floor of mouth or gingivolingual sulcus. Margins are irregular and well defined. Surrounding tissue is normal. Dentition is 2123 by 2123 on right side and 2113 by 2123 on the left side. Lower incisor gingiva appears hyperpigmented. Normal dental occlusion. Neck appears normal with no fullness. This is the picture. On first picture, we appreciate the deviation of tongue to the right side on protrusion of tongue, but there is no restriction of movement. Now on palpation, inspectory findings were confirmed. Mouth opening is 5.3 centimeter, the interincisor distance that is equivalent to 3 finger breadth of the patient. No local rise of temperature present, mild tenderness present around the growth, no loss of sensation in infraorbital and inferior alveolar territory. Lesion is hard in consistency and indurated and do not extend beyond the margin of the lesion. Induration palpable at the base of growth of size 0.5 centimeters. No temporomandibular joint tenderness or irregularities there. Soft palate and uvula is central on mouth opening and also symmetrical. Gingivobuccal sulcus is normal. There is no neck nodes palpable. This is a video showing the movement of the tongue. There is a growth on the right lateral border of tongue, but there is no restriction of movement. Possible donor areas. Bilateral upper limb is normal, no scars. Bilateral radial and ulnar artery are palpable with positive Allen's test. Bilateral thighs are normal. Chest is normal, no deformities or scar. Neck vessels are palpable. My provisional diagnosis for this patient is a proliferative lesion of right lateral border of tongue in a 43 years old male child patient, likely to be malignancy, most likely squamous cell carcinoma of clinical grade T3N0, stage 3 without any complications. The final staging of metastasis we can do after radiological investigations. May I go proceed, ma'am, to investigations?
Yeah, you can.
On investigations, I would like to do an MRI of face, computed tomography of head and neck, routine blood investigations with pre-anesthetic checkup, metastatic workup like chest X-ray and ultrasonography to rule out any lung metastasis or any liver metastasis. I would like to do right hemiglossectomy with 1 centimeter margin, with right-sided modified radical neck dissection plus left supraomohyoid neck dissection with free flap reconstruction using radial artery forearm flap. My first choice is the free radial artery forearm flap.
Wait.
Yes,
I think you can stop your presentation here and panelists will start discussing. Okay.
Yes.
So
Yes,
you gave the treatment aspect till that. So details can be discussed by the panelists. Okay. So
yes,
they ask questions, you can show your plan. I request the panelists to start asking the questions. 40 minutes will be given for discussion.
Okay, I'll start with the permission of other panelists. I would like to ask a few questions. You had Dr. Shivas and Dr. Karthika. You told that there is a history of pain in this thing. Can you describe the pain again and tell me what is the possible cause of pain?
Sir, the pain. Sir, on pain was he noticed a growth since 6 months. Then for 1 month, he was not complained of any pain. After 1 month, that is 5 months ago, he started experiencing pain when the food part while chewing the bolus when comes in contact with the growth, and which that is of burning type, and it on chewing it radiates to the right temporal region.
Okay. What do you think is the cause of pain?
Sir, pain, it could be any nerve involvement might be there.
Which
Uh,
nerve? That's the question.
Sir,
Which
lingual
nerve?
nerve involvement.
Lingual nerve. Can you tell what is the nerve supply of the tongue?
Sir, nerve supply of the tongue anterior to first general visceral afferent. The nerve supply of the tongue anterior to third is supplied by the lingual nerve, and for general sensation, taste, touch, pain, and chorda tympani nerve, that is a branch of facial nerve, is that supplies for taste sensation. Posterior 1/3 of tongue, the nerve supply is glossopharyngeal nerve, that is a ninth nerve, and the posterior most part of the tongue that is supplied by the vagus nerve.
Okay, this is the
And for
Correct.
motor supply, all the muscles of tongues are supplied by the hypoglossal nerve except the palatoglossus, that is supplied by the cranial accessory.
That is supplied by the
Cranial accessory part of.
Okay. Then thank you. Very good. Then you tell me, sir, there was one thing you told that dental department had done some biopsy. What was
Yes.
the report of that biopsy?
Sir, it was squamous cell carcinoma, sir. Yes.
Okay, so you should be mentioning it in history also, that it was squamous cell carcinoma, and based on that, further treatment was started. Okay, that's all from my side. Other panelists may ask.
Okay, Dr. Vinay. So, Shrivas, tell me, you have said that you will get both MRI and CT scan done in your investigations. So, what is the purpose of both of them?
Sir, CT scan, sir, for CT scan, we are doing to rule out the any bony involvement is there, and for the and MRI is to rule out to know the number, extent, size, and any other, and also lymph node status.
So, are you sure you will get a CT scan done in this case? Because you said that your lesion is not involving the floor of the mouth. There is no involvement of any soft tissue immediately adjacent to bone. So, MRI and CT scan, if you have to choose one, which one will you
MRI.
choose? Okay. And do you think if you get an MRI, then you can get an idea about the involvement of bone? Yes or no?
Yes, sir.
You will get an MRI. With MRI, you can get an idea of the
Bony
involvement also. To some extent, yes, you will get.
Yes.
Okay. So, what is your plan? You said it's going to be a hemiglossectomy.
Yes, sir.
So, how will you be sure that if suppose your lesion is around, how much away from the midline?
Sir, it is one. I'm showing, sir. Sir, the extent is from midline, it is dorsally, it is 2 centimeter away, and ventrally, it is 1.2 centimeter lateral.
And how much margin will you take?
I will take 1 centimeter margin, sir.
So
for wide localization, but for hemiglossectomy, we will remove the 50% of the right side.
So you mean to say that regardless of the lesion, you will go for a hemiglossectomy?
Yes, sir.
So you will go for hemiglossectomy or you will go for 1 centimeter margin?
Sir, I will go for hemiglossectomy.
Why?
Sir, for since the whole anterior that side of tongue, the lymph node lymphatic supply is same, that drains to the.
That is a very different thing. Lymphatic supply is same for so many things, but if you are getting clear margins, you think you should excise the whole of tongue posterior 1/3, because hemiglossectomy will then incorporate everything. It is very far from the tip. You will have to excise the tip also.
Yes, sir.
So why will you go for a hemiglossectomy with a small lesion like this?
Sir,
It's not small, but you will have to excise too much. So there is no concept of margins, that means in tongues.
actually, this is after he has also received the chemotherapy session 1.5 month ago.
So then,
So
why
he
did he
was
receive chemotherapy first? Was the lesion very big initially?
patient was giving the history that the pain is reduced to very mild extent, and growth is also reduced
But in
somewhat.
tongue, do you think giving chemotherapy first is
No.
a routine
No, sir.
treatment
Sir,
modality?
elsewhere he received chemotherapy, but in dental department, but it is not. I don't think chemotherapy should be given to this. Hello?
So if have you, classified the tumor and have you staged the tumor? What will be the staging in this case?
Sir, for sir, clinical staging, sir, for
Yes.
stage 1. Yes, sir.
I'm asking you, what will be the stage? You know, even if suppose
Yes,
you
sir.
do not remember
This is,
stage
sir,
1.
stage
So-
3, sir. This case is a stage 3.
So how will you in TNM staging? How will you go TNM classification and TNM?
Sir,
What will be the T, N, and M of this tumor?
sir, it is a T3, N0, and M0 also after
Are you sure?
ruling out the metastasis.
Are you sure that after chemotherapy it is classified like that or it is graded like that? Is there any in
Because
this
on present,
classification, if you give chemotherapy or radiotherapy and then after that you try to classify, does the classification change?
no, sir. Sir, yes, sir. Classification might change.
Might
Uh,
nahi, you have to tell. What is the term? How do you indicate when it is not possible to classify the tumor or grade the tumor? What is TX?
TX, sir, when the tumor could not be assessed.
So in this case, what would you say? Is it possible
Yes,
to
sir.
assess the tumor? It is not
Yes.
possible to assess because your chemotherapy will reduce the size of the tumor. So you do not know the margins anymore,
Yes, sir.
right?
Yes, sir.
So at the time when the chemotherapy was given, you don't even know whether it was crossing midline or not.
Yes, sir.
So then how will you confirm all that? Now, okay, chalo, forget that because that goes more into the onco part. So you will do hemiglossectomy and you said you will do a radial artery forearm flap,
Yes, sir.
right? So the floor of the mouth will be excised or not?
Sir, floor of mouth, there is no involvement of floor of mouth, but after doing radiological investigation, whether any
So will you also excise the posterior 1/3 of tongue or not?
posterior 1/3 in this case, it is not advisable.
Why? What is the difference between the anterior 1/3, anterior 2/3 and posterior 1/3? Is there any
Anterior 1/3 is,
anthological difference?
yes, sir. The anterior 2/3 of tongue is derived from the first pharyngeal arch, and the posterior 1/3 is derived from the third pharyngeal arch.
So there is a difference in lymphatic drainage also?
Yes, sir. Posterior
you don't-
1/3, yes, sir. Posterior 1/3 supplies the upper jugular chain, sir.
So you don't need to excise the posterior 1/3. So your floor of mouth is not being opened. So if it is not being opened, how will you pass your pedicle down? What vessels will you use for anastomosis?
Sir, facial artery or superior thyroid artery.
So what will be the vessels you will use for anastomosis and then wherever you are planning to do the anastomosis, in the neck or
In the neck,
some other
sir.
place? So how will you pass your pedicle in the neck?
Through the floor of mouth, sir. Yes,
But that is
we
not
will,
open.
sir, we will give the on neck incisions we will give, and
Neck incisions you will do, but how will you pass the pedicle from the oral cavity into the neck? You said the floor is not open, so how will you do that?
sir, from the floor of mouth, sir.
Okay.
Floor of mouth, we will pass it through the floor of mouth, sir.
So what are the advantages of using, why are you choosing radial artery forearm flap and not ALT, not MSAP? There are so many other flaps you have, PMMC,
Yes, sir.
PMMF. You know, PMMC meaning with the skin paddle, without the skin paddle.
Yes, sir.
There are so many options. So why have you chosen to use radial artery forearm?
Sir, radial artery forearm flap for hemiglossectomy, it is a uh, uh, it is a small size.
It's the best flap for it. I mean, I'm just asking, is it a good flap for tongue reconstruction?
So we can also plan for free ALT flap also.
No. Why have you chosen radial artery? We can do so many things, but
Yes,
you
sir.
have chosen to do radial. So why? I'm not saying it is wrong, but what is your reason for using radial and not ALT, not MSAP?
Sir, because it is having long pedicle length, and
You mean to
also
say
the
ALT will not reach?
no LT also will reach.
So once
And
once a flap reaches the pedicle length is of no use. Extra pedicle length, what will you do? You'll have to cut that.
yes,
So that
it
cannot
is
be the reason
thin
for your
flap,
choice of. Okay, thin pliable flap. So
thin
what is
flap,
the advantage of
pliable
using
flap.
thin pliable flap in tongue?
For sir,
Okay.
the form, it will restore the form.
Is it the form you want to restore? What about the function? What are the functions of tongue?
Sir, post-op mobility will also be much more easier in case of radial artery forearm flap.
So what is the design that is when you do the inset in radial artery forearm flap? What is the design known as?
So we for hemiglossectomy, we will measure the defect with the posterior extent and the length of the tongue,
So
and
what
accordingly,
approximately will be the width of the flap that you will require in hemiglossectomy?
sir, it will be approximately 8 centimeter, 7 centimeter the hemi circumference, and okay, it will be a cone shaped. Will be.
Cone shape. Okay. And what about the innervation? Do you innervate the flap? Is it of any use?
Yes, sir.
You innervate. So
Yes,
which
sir.
nerve is used for innervation?
Sir, we will use, sir, lateral antebrachial cutaneous nerves.
Of
Yes, sir.
which nerve? Lateral
Sir,
anterior nerve in the forearm.
two
Achha,
lingual
it
nerves, sir.
travels with which vessel?
Sir,
When you are
superficial
harvesting-
radial nerve, sir.
Are you sure you will take the superficial radial nerve?
No, sir. We will not take the superficial radial nerve, sir.
Okay. So then what is the nerve supply of the radial flap that you are harvesting?
Sir,
Because that is the nerve you would like to take, no? The flap which is
sir,
supplying the flap.
the lateral antebrachial cutaneous nerve, LABC.
Okay. And what about the motor function?
Sir, motor function.
And this nerve runs with which vessel? Does it run with any particular vessel?
The superficial radial nerve, sir. It runs along.
Nerve runs with another nerve. No, I'm talking about vessel. It runs with some.
Vena comitans. No.
Okay. Let's move on to the next thing. What about the motor supply? Are you able to give any motor supply to the tongue reconstruction?
Sir, motor supply we do not need because it is a case of hemiglossectomy. So the contralateral part.
Okay, if it is not a hemiglossectomy, total glossectomy, you are doing an ALT flap or any other flap, then what nerve will you use for motor?
Sir, for ALT flap, sir, LCFN, sir, lateral cutaneous nerve of
For motor function.
femoral nerve.
Is there any, is there any indication for using a motor nerve here? When you are doing an ALT flap or when you are doing a radial artery forearm flap, there's no point because there is no muscle there. And even if you do, so okay. Okay, I think
if you are taking muscle,
Dr. Selva or anybody would like to ask anything.
Other panelists, sir, wants to ask any question?
Sundar, Dr. Shelva.
Yes, madam.
Yeah, please ask some questions.
Yeah.
Aside.
Yeah. So you mentioned in the examination. So see, we are showing because there's a lot of difference between in-person examination and a PowerPoint presentation. But you are showing both the pictures simultaneously, one before chemo and after chemo. I think as Vinay sir pointed out, you should show only one photo because now you are examining only after chemo. So you should base all your examination on only one thing. What you see now, you can't combine both the photos during the presentation because it's quite confusing for us to see the size, everything on the patient, because one is with hair and other is without hair.
Yes.
And second thing is, you mentioned about the temperature on examination. So during in intraoral lesion, will you be able to assess the temperature?
Immediately, no.
So intraoral, definitely they have always saliva, so some want to be that, but
Sir,
generally we will not be able to assess the temperature intraorally for any lesions.
cold intolerance.
Yeah. No. Okay. No. This one, you are in intraoral examination or doing the ulcer examination, you mentioned about the temperature also. No?
Yes, sir. Yes, sir.
Tenderness, temperature, that's what I'm saying. So it should not come as routine because the intraoral we just cannot monitor the temperature. Then in the forum, you mentioned about Allen's test. Can you just a little bit elaborate on how you quantify the test and how you do the test and why you do the test?
Sir, we do it for the patency of the vessel, sir, patency of the palmar arch. We block the radial and ulnar artery simultaneously with the use of with two hands, and then after 10 seconds, we open up one of the we open up one of the vessel. I mean, we remove the pressure from one of the vessel. Like if we block both the arteries, and then I will block the radial artery, remove the pressure from the brachial artery, then we can see the uh, uh, return of the circulation on the hand within 5
So
seconds.
Which one you remove?
Yes, sir.
Can you demonstrate because you both are available? So
Yes, sir.
you
Ma'am.
can
Yes, ma'am.
demonstrate and explain what you are doing.
So we will
ask the patient. We will ask the patient to clench his fist and move it 2 to 3 multiple times.
Not visible at all.
Yeah.
So,
so I think you have to close the presentation and
yeah.
We will block
camera.
the. Hello, ma'am. Is it visible?
No.
You
have to close the presentation first. Presentation should be stopped. Then, yeah. Now you can show the camera.
Yes.
Yeah.
I will ask the patient. First, I will block both the arteries, radial and ulnar artery, and ask the patient to clench his fist multiple times, around 4 to 5 times.
Why you want to do like that?
So that the all the venous outflow will be drained out.
Very good. Go ahead.
Yes. Okay, stop. Now I ask the patient to stop, and then I release one of the. I will release the one of the artery pressure, and we'll see whether the redness is appearing on the palm or not. So within 5 seconds, it should be.
So can you little more elaborate? You see, the thing is, you should specifically see. Now you want to see whether the ulnar artery supplies the remaining part of the hand after the radial artery is removed. I think that's the point. No. So which one you should release and see?
Sir, sir, radial artery.
No, I didn't get my question.
So to see the patency of ulnar artery, because it is a dominant artery, sir. Ulnar.
Okay, so which one? How you have to assess the arch? So which one you have to release first?
So we'll release the ulnar artery.
Ulnar artery we will release first, sir.
Release. So what is the duration you have to check, and where you will check the
in the palm we will check
erythema or the redness.
Palm in which area? Sir is
thumb.
Thumb.
On the thumb. Area?
On the thumb.
Yeah. So it should be more focused. You have to check whether Yeah, yes. Yes, so it should cross the arch is patent means you should cross. And what is the time duration? That also matters. Actually, if it's too much delay, then it should be taken into concern.
If it
So
is
ideal
more
time
than
is
5
around 6 seconds, 6 to maximum. Can go. Yeah, that has to be done. One and then see in the photo you showed there is slight deviation of the tongue to the right side.
Yes,
so what do you expect? What could be the reason for it?
sir, due to the growth is involving the intrinsic muscles, the intrinsic deformation of the internal deformation of the tongue, sir, it is there, and so it is uh, deviating towards one side.
Okay, so what are the muscles, intrinsic muscles?
Intrinsic muscle, there are 4 pairs of intrinsic muscles are there. Superior longitudinal muscle, inferior longitudinal muscle, transverse and vertical muscles.
Okay. So one more thing you mentioned, there is a drooling of saliva.
Yes,
a lot
sir.
of drooling of saliva. So what could be the reason? So it may
The patient is
mean
not
that
able
there's an increased salivary secretion.
Yes, sir.
So you mean there's an increased salivary secretion or not able to swallow? So what is the reason?
Sir, it may be the patient not able. Patient is not able to swallow the saliva, and also due to the pain, the secretions increasing.
So just since you just mentioned very good about the detail about the supply, nerve supply. So what is the nerve supply for the salivary secretion?
Lingual nerves.
Auricular.
So they are also supplied by the same chorda tympani and glossopharyngeal, but there are parasympathetic fibers through the salivary nucleus. They supply the same thing.
Yes.
So because of their nerve irritation, they cause increased secretion of salivary secretion, but they also travel through the chorda tympani and the glossopharyngeal. So that causes an increased secretion.
Yes.
And in one of the things you mentioned, it's actually just about the history. I just want to ask, you mentioned it's a patient Hindu. May I know the reason for the religion? Is there any importance with the history? Is there anything to do with the patient diagnosis or anything with the religion? Just I want to, it's not a sarcastic question. Just I want to really know whether there's anything important to the diagnosis or that's a
because
routine to ask about the religion. Does it carries any importance in
because
this case, or any case for that sake?
Because many other most Hindus are mixed diet and a vegetarian diet. So the bony is the sharp tooth. It will get less traumatized. It may be the reason, but there is no other.
Personal history will be asking those things. Okay. Okay, that's all from my side. Madam.
Sundar sir. Dr. Sundar.
Good evening, Srivatsa and Karthikeya. I think
evening, sir.
Your history was quite clearly audible. What is your diagnosis at the end of the history?
Sir, it is a proliferative ulcer. No, sir. No, sir.
At the end of the history?
Yes, sir. A proliferative lesion of right lateral border of tongue in a 43-year-old male patient likely to be malignancy.
Yeah, this is at the end of the examination. At the end of the history, why I am asking.
Okay, sir. A proliferating lesion over the right lateral border of tongue in a 43-year-old male patient, and it is likely to be malignant, but we have to confirm it after doing the general and local examinations.
The reason I'm asking is that you mentioned that the history is sudden in onset. So are malignancies sudden in onset?
Sir, yeah, it actually after The patient experienced trauma due to it's while chewing. So then after he experienced then after he noticed an ulcer over there, and which healed in within 1 week, and
So
after that the growth has
trying
occurred.
to, what I'm trying to get to is that subsequent to your examination, now it's quite clear that this is a malignancy. So this sudden onset doesn't fit into your history. So it is okay to go back and ask to the patient once again so that your findings are in conformity with your final diagnosis. So this is for the postgraduates, not just this case, any other case. Make sure that your history examination is watertight. If there is something which doesn't fall in place, go back, ask the patient again, reconfirm. That's what I was getting at. And any major case, it is good to ask for history of allergy to any medications and bleeding disorder. Make it a standard habit. It will help you in practice later. You mentioned about the staining of the teeth.
Yes.
Did you look for any caries in the teeth, history-wise,
Yes, sir.
examination-wise, and what is the implication in an oral malignancy case?
Yes, sir. The caries there due to poor oral hygiene, and also it is relevant as he is a regular BD smoker, and also alcohol consumption is also present in his history.
So that points to the causation that smoking could have led to this oral malignancy. Other than that, what is the implication of poor dental hygiene in an oral malignancy case?
If there is a dental caries and if it involves it can be a loose tooth also, and the loose tooth can be if it involving the gingivobuccal or gingivolingual sulcus. So that is the also the.
What is the problem if there is severe dental caries and the patient goes for radiation after the flap is done? I'm asking a direct question. What is the role of the dentist with regards to dental caries, with regards to radiotherapy post your flap?
The tumor will shrink after radiotherapies, but on teeth caries.
There is increased chance of osteoradioid necrosis.
Yes, sir, there is increased chance.
Not managed and there is a radiation given. So all oral malignancy cases with a doubtful dental caries require dental evaluation before we proceed with the treatment. Now, in your list of investigations, what is a simple test to look for synchronous malignancies?
MRI face,
No,
MRI tongue.
clinically, in the OPD.
Sir, the biopsy.
There is field cancerization, no? So what is a simple test to look out for other
intraoral
in the aerodigestive tract?
Indirect laryngoscopy.
Yeah. So ideal has to be done. You didn't classify your defect. Are you aware of any classification system for tongue defects? So you just said hemimandibulectomy. If you have to list out a classification, what is the classification you use for tongue defect?
Partial glossectomy would be there. If we are removing the wide, 1 centimeter margin, if we are removing wide local excision, it can be a hemiglossectomy. It could be a subtotal glossectomy or total glossectomy.
Are you aware of Cheng's classification?
Cheng's classification?
For tongue defects?
Yes.
Okay, it is more or less similar to what you have said. It is just gives in percentages. What is this whole idea of classifying tongue defects in terms of percentage of volume that is removed? What is the philosophy? By knowing how much is resected,
yes.
Is it going to indicate what flap to be used and how? What is the philosophy?
Sir, if we are using in case of total glossectomy.
Sir, it is dependent on the muscle bulk also, sir. What percent of the muscle tongue bulk is to be resected?
And also the floor.
Yes.
So let's say it is lesser amount of volume is removed, like if it is partial to hemi, then what is your choice? And on the other hand, if more is removed, what is your choice?
If less is removed, if 30% of the, if less than 30% of the defect is removed, then we can close it primarily also. But if more than 30% and we can prefer the radial artery forearm flap or the lateral arm flap or MSAP we can use, and ALT also we can use.
Total, why is radial forearm not preferred? I'm trying to quickly wind up the discussion.
Sir, because radial artery won't provide the adequate bulk required for the total after total gastrectomy.
So you're saying in a lesser resection, bulk is not needed, a thin flap is needed, and in a larger resection, bulk is needed.
Bulk is there.
What is the philosophy? Why is this so?
Sir, in larger resection, the floor of, if in case of floor of mouth is involved, and if we are doing a total glossectomy, so we need to cover that. We need to fill the floor of mouth also, and that's why we have to
about
cover
filling
that.
the mouth, or is it about helping deglutition?
Yes, and also it helping deglutition and speech.
Better functional outcome, we'll have to use a much bulkier flap.
So to put it simply, in a lesser resection, the remaining tongue should be able to move your flap around. So it has to be a thin flap.
Yes, sir.
Whereas when the resection is larger, you need bulk so that the patient, by mere closing and opening the jaw, is able to now get the bulky flap in touch with the palate, and that will facilitate swallowing.
Yes, sir.
You didn't mention what incision you will take. What is your approach? Are you going to do a lip?
Sir, we will go with the, if for neck dissection, we can give a visor incision also,
If you
or
have
Schobinger.
showing the approach and procedure, you show, because you didn't, you just gave the diagnosis. You can show the slides if you have.
This for no slides for incision.
Okay.
Incision, Schobinger incision, I will prefer, which the incision is traverses from the mastoid region up to the midline, and also S-shaped incision from the middle of the that incision. We will vertically S-shaped incision we will make.
So for the primary lesion, what is the approach? Will you do the tumor first or the neck first? What is the sequence?
We will do, sir, neck.
If so, what is the reason?
Sir, neck first, sir.
No. What is the idea behind that?
Sir, because the spreading might be there. In case if we remove first the tongue, if we remove the primary, then the chances of spread is higher as compared to the.
What is commando operation?
Combined mandibulectomy and neck dissection operation, sir. Okay. In that case, yes, sir. Hello.
Is there time, madam?
Show the plan you have made. You prepared some plan, no?
This is the free radial artery forearm flap. So I have made the template according to the shape of tongue, what we have to need. the size of length of tongue, we have taken the 8 centimeter and the 7 centimeter, and through with the help of handheld Doppler, we palpate the artery, radial artery, and the cephalic vein also, and the required pedicle length of near 10 centimeter, and we can harvest the radial artery forearm free flap.
So how will you choose which hand to use?
Sir, non-dominant hand, sir.
So this patient is a left hand.
Yes, sir. This patient is a
Dominant?
left-handed. That's why we have chosen the right hand for this patient.
And see, in this case, if you see your marking is much away from the radial artery, actually it should be little more medial, I believe. You just see where is the radial artery marking which you have shown for that one. The radial artery is almost at the end of the medial, margin of the flap. The way you have marked, I think, especially in the distal half of the flap, it is totally away from the radial artery.
Where
Yes.
do you find the pedicle?
Yes. Ma'am, we will draw a line.
Between the FCR tendon and the.
Yeah, tell.
We will draw a line, imaginary line from the mid cubital region and up to the scaphoid notch, and that is the radial artery.
Between the brachioradialis
That
and
is the pedicle runs.
Yes, and it's
Yeah.
between the flexor carpi radialis and brachioradialis, sir.
Yeah, just here, where is FCR?
Why in the snuff box? Why can't you palpate it in the wrist?
Yeah, sir, because we,
Where you normally palpate radial artery?
sir, at
For a
the
routine taking of
radial
the pulse.
styloid, over the radial styloid, sir.
Okay, so there you will palpate the radial artery. So if you draw that line, what you are saying, from the cubital fossa up to the point where you palpate the radial artery, where do you think will the line be? If you can just use the pointer and point that. Distally and proximally, if you can just point where your radial artery will lie. Yeah.
Sorry, sir.
From that point up to the mid.
Are you sure
mid
radial artery is so little?
Thoda sa.
No, this point where you have put this end here, where you can see distally, here where will be the radial artery? Is it absolutely lateral or is it slightly more medially than what you have drawn?
Slightly medially.
It will be slightly medial.
Correct.
From the
So,
we are drawing the line.
Yeah, and here you will palpate the
radial artery.
Brachial, yeah. Brachial you can palpate in the cubital fossa, right? So then you can draw a line between the two. So if you see your flap is almost on the edge of the vessel. That is what Dr. Selva was pointing out. So your flap should be a little more on the medial aspect.
Medial aspect.
But how much medial can you go? What is the limiting factor when you are
At the boundaries.
medial boundary?
Medial, sir, medial boundary, sir, we can take the up to the.
Yes, you're right. Up to
medial ulnar aspect, sir.
Correct. So ulnar aspect, up to what point of ulnar aspect? Do you have to be careful about something?
Yes, sir. We should not damage sir, FCU till the FCU. We can harvest it.
Okay. Okay.
So
time is over, sir.
Where does the radial? Yeah, fine.
The PG teams can now ask the questions one by one. So the team one.
Yes, ma'am.
Yeah, you ask questions to the presenters, presenting team. Only 2 minutes time will be there for you.
Yes, ma'am. What is Hayes-Martin approach to prevent marginal mandibular nerve palsy during neck dissection?
Here's Martin approach. No idea. Sorry.
Oh, you have to answer.
Yes, ma'am. By various studies, it has been proven that the facial vein is more constant relation to the marginal mandibular nerve. Hence, in this, we'll be ligating the facial vein about 2 finger breadth below the mandible. And after ligation, we have to superiorly reflect the flap along with the superficial fascia so that the marginal mandibular nerve will be also retracted, thus preventing the injury.
Okay. Thank you.
Good evening. Myself, Team Jipmer.
Good evening.
Any other flap in the forearm other than radial forearm flap, which can be taken
Ulnar
as a
artery
flap?
perforator flap we can use. Lateral arm flap we can use.
Okay. What is the advantage of that flap compared to the radial artery flap? Advantages.
We can primarily close it also.
No.
More,
Can I tell?
More perforators as compared to the radial forearm flap.
No, not. I will tell the answer. That one is the advantage is it will be less hairy skin compared to the radial forearm flap,
Okay.
and also it won't be easily visible. The scar won't be easily visible because it will be covered on the radial another side. The scar won't be easily seen. That is the two advantage.
Okay.
Team 4. Team 4.
Yeah, from Stanley Medical College.
Yes.
Yes.
There are a few muscles present in the tongue. Can you name it?
There are intrinsic and extrinsic muscles. There are 4 pair of intrinsic muscles: superior longitudinal, inferior longitudinal, transverse, and vertical. And extrinsic muscles are genioglossus, hyoglossus, styloglossus, and palatoglossus.
Okay.
Team 5.
Yes, ma'am. Good evening.
One
There-
by one, you introduce yourself and ask the questions. We need not announce.
Okay, ma'am. This is Team 5. While harvesting a radial artery forearm flap, we can encounter few of the anatomical variation. Can you name a few of them and which is the most common one?
No, sorry.
So we can have a tortuous configuration of the radial artery, or there can be hypoplasia, there can be stenosis, there can be radial artery loops, or there can be high origin of the radial artery itself. So the last one is the most common one. Thank you.
Good evening, from Bangalore Medical College. My question for today is, what are the loco-regional flaps apart from the commonly used PMMC flap?
We can
for
also use,
tongue.
we can also use facial artery myomucosal flap, and also we can use submental flap, and these 2 flaps we can use.
Okay. The other flap options can be nasolabial island flap, infrahyoid myofascial flap, trapezius musculocutaneous flap, pedicle submental island flap.
Yeah.
Thank you.
Madam, just can I intervene, ma'am, for a moment? This is Dr. Selva.
Yeah, please.
See,
You
the
can. You
submental
always.
see the submental artery flap very, very carefully in the case of tongue, because we are doing a neck dissection, and especially in a male, it's totally contraindicated. The chance of recurrence is very high because when we dissect, very difficult when they do a node dissection. And though for namesake, we should not name all these flaps, because practically the chances are very, very less than. If you ask most of the surgeons here, they will not accept any local flap for this defect, especially. Though we can.
I 100% agree with you, Selva. And also that question about the advantages of lateral arm flap and the ulnar artery flap is not actually, it cannot be taken because it is not evidence-based. The lateral arm flap is not as pliable. So it may have lesser donor site mobility, but is definitely going to affect the mobility of the tongue because it is not as pliable. So those two things are not actually, you cannot take it, as there will be a lot of, I think, disagreement amongst the surgeons who are doing the reconstruction in tongue about these advantages and disadvantages. I don't think these questions, these two questions, as you said, one and that one, can be taken absolutely as a correct answer.
Thank you, madam. Thank you, sir.
Thank you.
Panelists can contribute after the answers. So, next team.
This is from CMC Village. Is there a scoring system to assess the swallowing capacity of the reconstructed
Be
tongue?
loud.
Is there a scoring system available for assessing the swallowing capacity of the reconstructed tongue?
Your voice is not visible.
Hello?
She is asking, is there a scoring system for tongue swallowing for tongue and the function of tongue? Is there any scoring system that exists for that?
Post-operatively, after tongue reconstruction.
Yeah.
If
there is a classification, I'm not able to recall the name, which determines the quality of speech, the quality of the ability to swallow. Both are there in there.
Answer your question.
Yes, ma'am. It is called the swallowing ability scale, which takes into account the method of food intake, the consistency of food intake, and the time duration taken for food intake. Each has 5 scores, and totally 15 is the maximum score. Thank you.
Is there any name given for that scoring?
Swallowing assessment score, SAS score, ma'am.
Swallowing assessment score. So these components also, how you give the scoring? 15 means?
Each has 5 method, whether we take totally oral or need for assistance, and the consistency, whether all foods are able to swallow or liquids or viscous, and the time duration.
Is it acceptable, panelists?
I'm not sure actually. Where have you read this scoring system? Because there are many scoring systems which appear in the papers. So has it been acceptable or has it been validated for Indian patients? There are a lot of things that you need to actually confirm before you accept a scoring system as a standard. And I'm not sure if it is a standard scoring system. I don't know. I mean,
any standard system, sir?
Is
there any standard system?
No, there is not. I mean, it is as far as I know, no. Because when we have to write a project, we have to get that validated first for the Indian patients, any scoring system. After that only it is approved by the ethics committee in India, in the institutional ethics committee, and it goes further. I don't know actually about this particular scoring system, but I will have to, who's the person who's asked the question?
Which team?
CMC value.
So where have you read that scoring system?
We are following it in our institution.
You follow at your institute.
Okay. Okay.
Is it described by any other person or you made it at your institute?
This is an acceptable system in European Association, but India we are.
Okay. Right.
No, it has to be universal system.
Even then, if institute is following, sir, that also can be known to people. So
it has to be published in a national journal or international journal somewhere. It can be acceptable.
She is
That
telling
can be taken as universal.
European countries it is used.
Which
Anyhow,
journal? Which
any
journal it was
journal
published?
name? CMC Value team.
Yes, ma'am.
Can you
Which
tell
journal?
me the journal and the author of the article?
It is available in the European Association Otolaryngology of Carcinoma of Journal, ma'am. Author Tarsitano from Italy, ma'am.
Okay, you share that article in group. Okay.
Yes.
Right. Next team.
Good evening, everyone. I'm Dr. Sri Krishna from Sabdajam Hospital team. I would like to ask, do you know any free functional muscle transfer options for dynamic reconstruction of tongue?
Gracilis muscles.
Okay, and any other?
We can also use rectus abdominis muscles.
Okay, any other option? In radial forearm prison?
No.
Hello. Okay, you can also use brachioradialis muscle along with the radial forearm.
Okay.
Oh, thank you.
Yes.
Yeah. Again, in this, just to add a point, ma'am, this has been, I also read this thing, but it's not very commonly done. The brachioradialis with this, because the bulk is very less and very not that much, I mean, used that often. It has been described in the literature. I read that article, but not commonly done. But for to mention, we can do that.
Okay, sir.
Thank
you.
Will get the marks for the answer. Even for asking question, he will also get. Yeah, next team.
Good afternoon. This is Sonika from RML Hospital, Delhi. My question is on examination, if the lesion is having a verrucous appearance, so what is it that we need to keep in our mind during while coming up with the diagnosis?
In verrucous lesion, radiation, we have to keep in mind the post-operative radiation.
Regarding the etiology?
The leukoplakic plaque, it is can arise. It is pre-malignant lesion, and
actually, we have to
it is
think it could be because of HPV. The
Yes.
papilloma virus could cause this lesion. And my second part of the question is, if the HPV status of the patient is positive, how would that differ your treatment plan?
In that case, we should aware that there is no active lesion on that for HPV, and also around the doors.
Right. So yeah, exactly. The answer is that the treatment plan does not really change. So we still go ahead with our resection the way we have planned and the reconstruction the way we have planned. Maybe in the post-operative period, we might give lesser dose of radiotherapy because HPV, the tumors because of HPV tend to have good prognosis. But other than that, the treatment plan remains the same. Thank you.
Thank you.
Next team. Likita, what is the next team? Any team is left?
BJMC Pune has not joined. The next team can ask questions.
What is the team you please announce? Is there any list with you?
Kilpauk Medical College.
Good evening, ma'am. This is Team 11. Can you please tell us some, if you want to provide any, if you want to take what precautions you will take while doing a radial forearm harvest, flap harvest?
While harvesting the flap, we need not to damage the superficial radial artery. We have to nerve. Superficial radial nerve should be preserved, and we should be suprafacial. The fascia, after we reach the level of that palmaris longus, we go inside the fascia, and then that at that time we have to be.
For majority of the dissection, it has to be suprafacial, and near the vessel, it has to be sufficient to
include the vessel and the nerve. If we want antecubital, that lateral antecubital nerve.
We also stay above the paratinum so that the graft take could be good later.
Yeah.
Thank you.
Yes. We can.
Any contributions from panelists or Kilpak Peji? Anything you want to add?
No, ma'am. No, ma'am. That's all. Thank you.
Okay. Then next team, MMC.
Good evening. Good evening, ma'am. I'm here.
Yeah.
Can you please throw some light on compartment tongue resection in case of CA tongue? Compartmental tongue surgery or compartmental tongue resection in carcinoma tongue.
Compartment.
So the compartment actually means that, for example, there are certain not only going wide by the margins, but going wide a lot. So why I'm intervened is intervened because this is not an acceptable in excisions.
Let her the question asked by MAMC New Delhi. Just answer the question.
Okay. It is not a destined procedure, but a newer concept tells that anatomical approach to the disease, that is CA tongue, is to remove the primary lesion along with its potential pathways of progression via the muscular, lymphatic, or vascular within the compartment. Now, the surgical excision is okay, but some articles say that long-term oncological efficacy is good.
Okay.
Vinay sir, please.
Yeah, so that's what I said. It is actually it's not acceptable at all. Only few people practice it, and it is not evidence-based. There have been multiple discussions. It's not a correct. See, what I would like to suggest here is that the questions that are asked, if they are based only on papers without evidence, there are multiple things that somebody might read and come up, and it may convey a wrong message. So to say that some people have said it doesn't mean anything. Nowhere in the world it is actually practiced like that, except maybe in a few institutes I know. In Amrita and a few other institutes it is practiced. But I guess still it becomes a standard of care. We should not take it as a correct thing, because might send a wrong. That's what my thought is. But
yes,
No,
sir. This is the reason why we kept this session, so that the PG should understand what will be what to be asked and what is relevant, what is not relevant. It will be quantified by the panelists of experts in the field, so that they don't go like deviate from themselves while preparing for exam. So that is.
I think
Yes, sir.
Dr. Satsang has rightly told. I think that we should stick to that way. Otherwise, you can make 100 questions, which is out of not exactly focusing on
Even
the.
PG should understand what type of questions to be put to the presenting team. Okay, so kindly concentrate on those aspects also, because you will be getting mark for a relevant question only. Okay, so next team is ESIC Faridabad. PG is there from ESIC Faridabad.
Ma'am, ESIC and SRMC have not joined, ma'am.
SRMC also not joined. Okay, you please make it as a absent.
Yes, ma'am.
And Bhuvaneshwar.
Good evening, ma'am.
Yeah.
My question is, could you please explain what do you mean by oral field cancerization?
Oral field cancerization was a concept given by Slaughter in 1953. It defines that whenever there is a primary oral cancer, after 3 to 5 years, there will be a second primary in the oral pharyngeal oral cavity region. And it basically the reason behind is that the cells have modified the cells have the carcinogenic property, but they may not be the synchronous lesion, but they may occur after 3 to 5 years, which was commonly seen.
My answer would be oral cancerization. It means that oral cancer does not arise as an isolated cellular phenomena. Rather, it involves multifocal development process, which is at various rates within the entire field in response to a carcinogen. And this is why oral cancers are prone for development of synchronous and metachronous tumors.
Okay.
Primary tumors.
Yeah.
Thank you.
Acceptable answer, panelists?
It's almost the same, ma'am. Actually, it's because of the genetic makeup there. All cells are equally affected and one can present at a different time.
Okay.
Yeah, it's good.
Ames Rishikesh.
Good evening, ma'am. This is Team 16 and Ames Rishikesh. My question to you is, what nerve is used to make your RAF a sensate RAF?
Lateral antecubital cutaneous nerve.
Okay,
LANC.
and at the you'd anastomose that too?
Lingual nerve.
Okay. Thank you.
Thank you.
All teams completed their questions. So any pardon? Is anybody left?
No, ma'am.
Okay, anything in the chat box? What is the justification in doing bilateral neck dissection in this case?
In case of in this case, the contralateral neck dissection is prophylactically we are removing the supraomohyoid because
it is N0. Why
yes,
you are doing the okay.
What are the nodes you are planning to remove in this case in the right side, which are the involved side? This is Dr. Silva. So what are the nodes you are?
What will you do on the same side? What all groups you remove? That is the question.
on the for modified radical neck dissection, we will remove the lymph node level 1, 2, 3, 4, 5, along with we will remove the spinal submandibular gland, spinal accessory nerve, and IJV, and if in case IJV and sternocleidomastoid muscle.
All you will remove.
Neck dissection.
So you will remove all the three structures.
We will preserve it, sir. If MRND3 we are doing, then we will preserve all the three structures.
So what I'm asking, my question is, what will you remove, or what dissection you are going to do? You may not say I may this. What will you be doing, and what will you remove? What dissection?
What will you preserve? What will you remove?
Only level 1 to 5 lymph node along with submandibular gland.
Okay. So it's more like it's a functional neck dissection.
Yes, sir.
Right.
Yes, sir.
So, 'cause, 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 ' So what is a synchronous and a metachronous lesion? Is it because you mentioned the word synchronous? So what do you mean by synchronous lesion?
Sir, synchronous lesions are the lesions which arise within 3 months, and metachronous are the lesions which arise after 3 months of the primary.
Usually it's around six months. It's
6 months.
Okay, sir.
Yes.
So do you do any frozen section in this case?
Yes, sir. We will send the specimen for frozen section to confirm the margin status.
Okay. So you send it for all cases?
Yes, sir. We send it for all the cases.
Generally, frozen section may not be required. With the practical aspect, we'll tell you, not required in all cases. Usually, it is sent if there is any suspicious margin. Usually, send it. Otherwise, because they even in the frozen section, they will not see all the margins. Usually, we mark 1 or 2 margins which are really we suspect or doubtful lesion, especially after RT other things. So that they will come back and we will link the margin and send it. They will get back saying that this is positive or negative. And
Yes,
so that's the thing. Usually, we will not say the entire every case. We don't send a frozen section. It's not universal, sir. But in case doubtful lesion, you should go for a frozen section.
Any delegates would like to ask questions can unmute and ask. Other.
Ma'am, there are a couple of questions. Sorry, sir. There are a couple of questions in the chat box. Shall I just read them out, sir?
Yeah.
How can we bring pedicle to neck if floor of mouth is intact?
Pardon, please.
No, this I think is to the panelists. The question was, how can we bring pedicle to neck if floor of mouth is intact?
So we just dissect the muscle a little bit of adequate length and deliver the pedicle down.
Remember, I asked this question during the discussion on the case. So you, as Dr. Selva is saying, you have to just make a small rent, or you can actually split the muscle, remove a little bit of muscle, because otherwise it might get swollen and compress the pedicle later on. So make some space, but you'll have to open the floor. Without that, it is not possible. So we have to make a small opening.
Yes, sir. The second question is, lesion is not crossing midline and is N0. Is it a protocol to do prophylactic contralateral neck dissection?
So again, here if you see, there are a lot of papers for it and against it, and there are also individual protocols for an institution. But I think I'm not a person to exactly say, but when they say prophylactic dissection as per the institution protocol, I think it not be a wrong decision. Because it's they said it's a T3 lesion, I think, because they're already going for an adjuvant. So it's little advanced tumor, so we can go for definitely consider for a opposite side the prophylactic neck dissection, supraomohyoid.
In this case, I think they will definitely do contralateral neck dissection because it was given chemotherapy. The actual extent of the lesion may be masked now because of chemotherapy. That is first thing. And the other thing is that in tongue, it is said that there is a lot of crossover as far as I remember. So mostly in tongue, a bilateral neck dissection is what is generally done. In cheek, you may get away with a single ipsilateral neck dissection.
Noted. So another question, another suggestion actually, suggestion from you. Any article or book to refer to regarding rehab of tongue post-operatively for swallowing and speech? Any guidelines or protocols that the students can refer to?
Book or guidelines? Guidelines may be there, which we have also got uploaded on, but they are not in great detail. They are more on reconstruction. And swallowing, yes, swallowing and speech therapy is required. So the patient has to be referred to the speech therapist. There is a lot of changes the patient needs to do in his lifestyle. So for that, yes, but I don't specifically know any book where it will be written. I can't. I mean, there are many oncology books, but in plastic surgery, I don't think too much of details is given in that. We can discuss it here.
Yes, sir.
Anything regarding the diet which they follow patient, especially after a total glossectomy, how will? So what will be the patient diet in the case of a partial glossectomy and a total glossectomy?
Soft, initially it will be the soft diet, sir.
Sir, we will diet. Sir, we will insert the Riles tube and we give the feed through the Riles tube initially. And
so how long you will be continuing the Riles tube feeding in this case?
Sir, for around 2 to 3, sir, we can for around 6 weeks, sir.
No, 6 weeks is too much. So usually for a partial glossectomy, a maximum of usually depending on the institution protocol, but a maximum of 2 weeks. There is no healing is well. If the neck is there is no evidence of any orocutaneous leak or anything, you can proceed with the oral diet maximum of within 2 weeks. But if you are really confident, even by 10 days should be a good time to start with. If there is a no neck collection, the healing intraorally, what you see is good. And in this case, if the floor is intact, definitely you can start with a 10 days time. And to begin with, start with clear fluids for a day or two and gradually increase to a semi-solid and solid diet.
Yeah.
And
what you have to be careful is that don't give very hard and hot food. The reason is that the flap is insensate. So if you give very hard food and the patient tends to, that food will accumulate on that side, may cause abrasions if it is very hard. And the other thing is that if it is very hot, again, that part might get burned or maybe damaged because of the temperature. So you have to check that. But since the other side is okay, usually it will be fine. I see two other questions in the chat box. One is there any method to restore the taste sensation? To which the answer is naturally it is not possible, because what you are doing is a radial artery forearm flap which does not have any such receptors which can be good for taste sensation. So taste sensation to restore is not possible. What we can do is, if the tip is okay, the tip is supposed to be rotated and cover the tip of the flap, so that the tip can be used. So you're getting my point. If instead of hemiglossectomy, the tip has been intact, that can be rotated to cover the flap so that the tip can be used. That is one change which you can do. The other question is, if you open the floor of mouth, how to prevent saliva entering the neck? So you have opened the floor of the mouth, but you have put in the flap over it. So the flap covers that part of the floor which is through which the particle is passing down. So there will be no problem for that. But you have to, that is how it will be passed from down. The flap is there, so the flap covers that small rent which is made.
So Naren said his question to the students, to the participating team. What is shape modified radial forearm flap?
Shape modified.
French bilobed in sir, we will use harvest the radial forearm flap by in the shape of the.
We can use a bilobed or we can modify the shape in order to cover the floor of the mouth as well as the lateral border of the tongue in case of hemiglossectomies.
Yeah, it's the most common is a bilobe design.
Yes, sir.
The main reason for doing that is to increase the
floor
mobility.
Of mouth. Yes, sir.
Yeah. So who designed first described this bilobe design? Any idea? Who published? No, just an additional question. It's one of the famous person. That's why I just want to ask. Urkane et al.
Urkane.
As far as I know, shape modified is by Matev, and it was about achieving primary closure in the forearm by taking along multiple perforators a longitudinal shaped radial forearm flap, which can then be configured to wider flap. And also recently published by team at Amrita.
Yes, I heard of. Yeah, I've seen that.
Mate.
So one last question and then we'll go to the next session, sir. This is for the panelists, I believe. What about feeding and total glossectomy?
Yeah, that's my question. Actually, I was about to ask complete that. So in a total glossectomy, I mean, the students want to try answering that.
Yeah, please go ahead, Dr. Silva.
Yeah, see that in a total glossy, the tongue plays a very important role in chewing and for grinding the food. So when the tongue is not there, they will not be able to mix the food properly. So in a case of a total glossectomy, that they will not be able to chew properly. So usually what they can, a mixed diet sort of diet, mixed food sort of thing, where they can directly swallow, such foods are given. And they usually change their habits like that, so that mixed food and like a jelly-like consistency where they can easily swallow, such foods are given. Basically, they can't chew the food because they were not able to use the tongue to rotate the food. So this pretty mixed food is given generally for a patient with total glossectomy.
Time is over for QA. So we'll go for the next session of this competition. Likita, share the spotter.
Ma'am, I just opened.
Yeah. 10 minutes time, please. Presenting team.
Yes.
Diagnosis, treatment.
A case of a case of either post-diabetic non-healing ulcer.
This is a pressure sore over right heel, probably calcaneum.
Yes, tell your treatment also.
Initially, if there is slough, we will try to debride the wound and ask the patient to maintain local hygiene, and also we'll give offloading shoes to the patient.
What features make you feel that it is a pressure sore?
Pardon, sir?
What features make you feel that it is a pressure sore? Why did you say that it is a pressure sore?
Sir, because it is on the pressure bearing area, and it is the sore is on the bone against the bony prominence in the dependent area.
So pressure sore will generally happen when a patient is lying down on a bed for a prolonged time.
Yes,
so
sir.
do you expect a pressure sore on that area, with that location?
No, we will expect the pressure sore over the posterior aspect, sir.
So this is okay. This may not be a pressure sore.
So this is a this can be a.
So this is a, sorry, repeat.
Non-healing ulcer.
Non-healing ulcer. This can be a non-healing ulcer.
Is it an acute non-healing ulcer or a chronic non-healing ulcer?
Chronic, sir.
Chronic non-healing ulcer. So what are the features which make you say that it is a chronic non-healing ulcer?
Sir, a trophic ulcer. It might be a trophic
That's
ulcer.
okay. But
And
what features?
non-sensate.
How do you make your judgment that this
Sir,
is
it is not inflamed. Sir, there are no signs of inflammation, redness around the wound.
And the bed.
There is gradual granulation tissue which is there.
Pale granulation at the bed.
What about the edges?
Sir, punched out edges. Sir.
Very good. So these three features are showing. So what could be the reason for this kind of ulcer?
Sir, it can be any patient with diabetes, diabetic foot. It can be, or any immunocompromised patient. If any.
Why do you say immunocompromised? Why will they have this kind of ulcer?
Please phrase your question, sir. Pardon, sir.
Why do you say immunocompromised? Why would they have this kind of ulcer?
Sir, post-traumatic, if there is any trauma-related injury or the healing, wound healing is not so.
Correct. So can you tell me just briefly what are the stages of wound healing which might have got affected in this? Which stage of wound healing might have got affected?
stage of inflammation, stage of proliferation, and stage of revascularization is there. So stage of prolonged stage of proliferation is there.
Okay. Other panelists may ask questions.
Okay, so you have mentioned so many reasons. You should also mention about reasons like a spinal injury or any nerve injury also. No? If the chronic ulcer,
yes,
I think that's also an important reason for such cases.
Yes.
And one more important finding, what you have to say is margin, that's increased callosity.
Yes, sir. Around the.
Indicates it's a chronic ulcer. So the first evaluation, apart from that, you should evaluate the sensation in the foot. Apart from the regular screening, you should also do the. So how will you proceed in this case?
First, we will counsel the patient to maintain a local hygiene and to prevent the further injury because it is a insensate area. And we will send the culture of this wound, and we will the diabetic workup and general blood workup we will do, and after daily dressing, and we have to excise the margin, and we will proceed debridement of the.
Sir, for further
Before going to that, no, will you at least do an X-ray to check?
Yes, sir. For to rule out any
osteomyelitis.
Osteomyelitis. To rule out osteomyelitis.
Yeah, bone involvement. And will you check the nerve sensation in the foot for say any case of trophic ulcer, especially in the heel? So what is the nerve supply in that area? What is the root level? Can you just tell me what is the nerve supply in that area specifically?
S4.
No, S4. So what's the nerve? At least tell me that, then we can see the root.
No,
it's a calcaneal branch of the posterior tibial nerve. Posterior nerve, when they give the medial and lateral plantar nerve, before that it gives one calcaneal branch. This will be the calcaneal branch of the posterior tibial nerve. The root level is, I think, it's S1, S2.
S1, S2.
So you have to check for the spinal level. In these cases, since you're not, you're just showing a picture, you should have a thorough examination. Apart from the routine history, also examine the spinal cord, deep tendon reflexes and the sensation in the other parts of the foot. Okay, then definitely you need an X-ray in these type of cases, because a chronic ulcer, look for any osteomyelitic changes. So then what will you proceed? How do you want to proceed in this case?
Sir, we like to provide a flap cover for this patient.
After debridement, thorough debridement, we will go on for the flap coverage.
So what flap cover you want to give?
We can do medial.
Reverse oral artery flap cover.
Medial.
We can also go for reverse oral artery flap.
Or medial
So
plantar artery.
You can also say, you say I will do.
I will do reverse oral artery flap cover.
So okay, will reverse oral artery flap reach this point? Because once you debride, I think it will reach the distal part of the heel pad. Will a reverse oral comfortably reach that area?
So medial plantar artery, I will like to.
Medial plantar artery. So it's based on
the medial branch of posterior tibial artery.
Okay. So what any other local flap? Any muscle flaps in that area?
So free local flap. EMS. EMS.
Flexor digitorum brevis muscle flap usually comes in that area. So other panelists, please.
Is this wound graftable? What is your disagreement with grafting?
Sir, it can be grafted, sir, but since it is a pressure bearing area, it will be further traumatization in the future, which will lead to unstable scar formation. And again, exposure of again, it will lead to formation of non-healing.
If you put a reverse sural also, it is likely to be insensate.
Sir?
If you put a reverse sural, that was one of your options.
Yes, sir.
It also is likely to be insensate.
Yes, sir.
That also can break down.
Yes, sir. That can also break down.
It's not that graft cannot be put. The thing is whether patient can maintain after your procedure, how well he can take care, how well he can offload. Those things are also important.
How will you improve the dermal component in skin graft? What is the procedure?
Madam's question has the answer in it.
So most of the time the examiners will do
Thickness,
It would be a thick graft.
thick graft, thick STSG or
It's a weight bearing area. That's why I'm asking if the patient is
can
not
apply
any flap and the conditions are not feasible. So how will you do strengthening of your skin graft?
we can apply dermal substitutes also.
Okay, that is one because it is available now, but olden days it was not there, isn't it?
Yes.
So at that time, how the surgeons used to build the weight bearing capacity with only skin graft.
Yes, ma'am.
So it is called overgraft. So repeatedly they used to remove the epidermis and put the graft. So repeatedly, if you do like that, the dermal component improve. Okay.
Okay.
So that
Yes,
is
ma'am.
the procedure called overgraft.
Yes,
Right.
ma'am.
Time is up, ma'am. Can we go for the
Yeah. Please. You maintain the time. Go for next. Quick diagnosis. What is it?
It is a 3D computed tomography CT reconstruction of skull showing the multiple pan facial fractures with leafold 2 and left parasymphysis mandible fracture and leafold 2 fracture and along with nasal bone fracture also.
Is it a panfacial fracture?
No, sir, it is not. Yeah, sir, it is no, sir, not panfacial. It is involving the middle and lower third of face, sir.
What is the definition of panfacial?
Sir, ma'am, if all the 3 levels are injured, if from the level of the root of nose and above the root of nose and up to the and below from the skull vertex up to the level of root of nose, and second from root of level of nose up to the nasal.
All are there now.
Yes, ma'am. All of 3 are involved.
Then, okay, go ahead. Mandible with one more bone or 2 a middle and a lower third or middle and upper third. All 2 zones are involved. Then it is called panfacial. Okay.
Yes, ma'am.
Yeah. Yes.
Can you quantify you said nasal bone fracture, it's more than that. Can you quantify it better?
nasoorbital ethmoid.
NOE.
Yeah. So
NOE fracture.
NOE fracture.
What else you are suspecting?
Sir, ma'am, maxillary, right maxillary, the incisor, maxillary incisor, right first and second, and left first maxillary incisor is also dentoalveolar
Dental fracture. Okay.
fracture is there.
In the mandible, I think that's another fracture also, I believe.
Yes.
And sir, maxillary fracture is also there. Left maxilla fracture is also.
Mandible.
Left parasymphysis fractures are.
Usually parasymphysis will associate with another fracture, and this is, I think that's present in this case also.
Right side, you just observe the view is not there, but the displacement suggests that there is what type of what fracture you will expect when there is parasymphysis.
Usually they always go hand in hand. Most of them, when you see this, you have to see that. That's a clue.
Condyle
fracture.
Subcondylar
fracture on the right side.
Opposite condyle will be right.
So usually when there is a fracture in the parasymphysis, you have to look into other thing also. Usually they can go hand in hand.
Do you expect what clinical finding do you expect in the eye?
Periorbital ecchymosis and edema, subconjunctival hemorrhage,
diplopia will also be.
Is the critical features you should tell?
Yes, diplopia will be
there. Notice.
Restricted mobility and diplopia.
Yes.
Okay.
And what about anophthalmos?
Anophthalmos can also be there, sir.
Why would you expect anophthalmos?
Sir, floor of orbit, if it is involved.
Can you tell what is a pure orbital floor fracture and impure orbital floor fracture?
If
in pure orbital floor fracture, only the orbital floor along with the part of medial wall is involved.
Yes. What about impure?
Sir, all other, including the inferior orbital region, the lateral, medial, and the superior orbit wall.
No, that is not correct. If the orbital rim is involved with your floor, we call it impure.
Yes.
What is the sign in CT?
Other panelist can ask.
So what will be your, how will you proceed in this case?
We will first we will reduce, we will do the fracture reduction. So we will operate this case. First, I will do the workup, blood workup and pre-anesthetic checkup, and then
concentrate on the main things.
And then
you reduce and all.
Ma'am, I want to
principles followed.
I want to go on first max. I am intermaxillary for
occlusion. First, we'll give maxillary.
So we will do in this case under anesthesia or without anesthesia?
We can, sir, regional anesthesia we can.
Which regional? What regional?
Sir, local.
So what regional?
And facial fracture.
Will you give regional in this?
No,
My
sir.
question
For
elaborate
intermaxillary session, sir.
Okay. So it's a fan facial fracture, so you want to reduce it. So what anesthesia are you planning to give?
Sir, general anesthesia.
So how will you give in this case?
And sir, open reduction and internal.
Sir, we'll give
what type of anesthesia?
Tracheostomy. Sir, we'll go for tracheostomy and then we'll give GA. Anesthesia.
Any other tracheostomy, or there's any other option?
Pardon, sir?
Any other type of anesthesia?
How we insert the
not
tube?
Tracheostomy. Any other?
Sir, we can go for submental intubation.
Exactly. So that in this is an exact case where you might require sometimes a submental intubation because you want to become IMF. So if you put an intraoral tube, it's very difficult. So you have to do an IMF because What's the most important thing you want to maintain in this case? Tell me, what is your outcome? The important thing, what will be the expecting outcome in this case? The most important outcome.
Occlusion. We have to...
Yeah, occlusion. That's a single most there are many things you will require, but the most important here is occlusion. So for that we need we can't have the tube inside intraorally. That should be so. Tricuspid is one option, but most commonly we can do, which is you can remove. So submental intubation is an ideal one for this type of patient. So occlusion is the most important thing for this type of patient. Yes, go. So how will you proceed? So here, first thing we want to say is how is the order? What order you want to fix it? That's the most important thing. The next question everyone is willing to ask you. So just go ahead for it.
Sir, first occlusion followed by mandible fixation, and then for maxillary and nasal ethmoidal region.
It's very vague. Can you little bit elaborate?
We will also check for condyle fracture and TMJ status. We will also check. So nasal fracture we will first.
Time is up, sir. Can we go to the next one?
Okay. So always go from fixed one to the, so from the calvary go from a fixed portion to the unfixed portion. So the calvary is a fixed portion, frontal bone. From there you can come down. So it becomes a fixed to unfixed area. And mandible you can fix. And just one question, for what is the approach for a subcondylar fracture here?
Sir, intraoral approach through we'll give the incision as a core.
I don't know. Intraoral, I think it's very difficult in this case. Intraoral for a subcondylar fracture, practically not possible. Either you should go for either people go for a submandibular approach or a preauricular incision. That's the best way to go. Intraoral cannot be done for a subcondylar fracture. Next slide.
Next session.
Yes, ma'am. One second, my system got stuck, ma'am. Just 1 minute. Yeah.
Instruments for liposuction.
Liposuction?
Or can the first?
Huh?
Only liposuction?
No, ma'am. Fat graft.
Thermal lipofilling.
Lipotransfer.
Lipotransfer. So first image is showing the cannula, long cannula with a eye at the distal end. Second image is the images of the connector which connected, and the third are the filters.
Fourth is the handle.
Fourth is the
handles
of the filters.
Handle with spring.
The injecting gun.
Yes.
In which they have the pre-filled syringes will be fitted to it and you will inject.
Yes.
So tell me about how you harvest and how you transfer. Can you describe the procedures?
Sir, under local anesthesia, we will first, after counseling the patient, and we will take the patient in operative theater. And under local anesthesia, we will inject a tumescent solution in the subcutaneous fat of region of abdomen, lower abdomen. And so, and also we mark the area how much we are, the area we have injected the solution, and around 200 ml of solution is injected, and then we insert the cannula, and we aspirate the fats.
You have to identify each component of this instrument and tell the importance.
How do you prepare
Okay,
it?
it's a zone of instrument. So first you concentrate on that and go ahead.
First one is the cannula, through which the cannula with eye, which is inserted inside the region we are preferring for lipoaspirate, the donor area. And second one is a connector that connects with the filter, and we will connect it further with that handle, and
to and fro motion, we will aspirate the fat.
What will you do with these things?
We press that handle, and negative suction is applied, and
what specific, this filters, any particular specific kind of fat transfer you are doing?
nano fat transfer.
Nano-fat transfer. So what are the indications for nano-fat transfer grafting?
In case of Peri-Romberg disease or hemifacial.
See, we are talking about nano-fat, no? There are different kinds of fat.
Yes, sir.
Okay, the nano-fat will be indicated in specific sequences. What is nano-fat?
Sir, the fat, the lobules, we are making the fat tissue, we are breaking into components, multiple small, so that surface.
So that?
Surface area is increased.
So nano-fat is a very fine fat graft, which is used for specific purposes. There are broadly two kinds of fat grafting. One is structural, then one is nano-fat.
Yes,
structural is for places which you told, hemifacial, microsomia, Peri-Romberg, because you want to give some bulk also.
Yes,
on the other hand, nano-fat is used for specific indication. Okay.
Yes, sir.
Can you think of some other indication where you can give nano-fat?
Below.
It can be given for
below
where you want.
Eyelid, lower eyelid, below eyelids are under.
Yeah, where you want fine fat, and particularly you want to exploit the stem cell component of the fat.
Yes, sir.
The cosmetic things.
Cosmetic purpose. So in
Yes,
scars, you can give it on scars. You can give it in eyelid, fine lines.
Depressed scar.
To give improved fine lines.
Rejuvenation.
Where we need fine surgery.
Okay. So these filters are used to make that nano-fat. When you pass to and fro multiple times, the fat breaks down into smaller components. After harvesting the fat and before preparing the nano-fat, what intermediate steps you have to take? You have harvested the fat using all the tumescent solution you told. What intermediate steps you need to take before you can prepare the nano-fat?
We separate the fat from other components,
yes,
like tumescent and the blood plasma.
How do you separate it?
And we will separate by the process of centrifugation. And after we will then aspirate the supernatant solution, and the left out fat lobule component is then we will through Tessari's method we will also make it thin so that it easily get injected inside the reliable recipient site.
Okay. And what is tumescent? What do you mean by tumescent?
Sir, it's a clean solution. We are
what is that? Describe. Why do you call it tumescent? Or what are the other methods of this anesthesia infiltration?
Tumescent because it provides a turgidity. And
yes, okay.
And basically, we have to
it helps in also vasoconstriction, helps in vasoconstriction, and also it used in a plane.
No, we are discussing about tumescent. We are discussing about tumescent, the technique. No? Tumescent is a technique.
Yes,
okay. Sir. A solution is made which is injected. So what are the corresponding other techniques for this kind of fluid infiltration? Have you heard of wet technique, super wet technique, tumescent technique? Right. So how are these three different? Wet technique is when the aspirate to the infiltrate ratio is 1:1.
1:1.
You're planning to get 20 ml of fat, you inject 20 ml of fluid. Super wet is maybe 2:1 or 3:1. Okay, and tumescent is a lot more than that. You're planning 100 ml of fat, you give 500 ml of solution.
Yes, sir.
Okay, other panelists, please continue.
Dr. Sundar Shelva.
Yeah. So what will be your mixture for the tumescent?
Sir, ringer lactate solution, adrenaline solution, and lignocaine solution, sir, too.
Okay. So
and hyaluronidase.
The indication for each one has some importance.
Sir.
Why? Oh, yeah, tell me. Why you want to use normal saline? Why you want to have ringer lactate?
Because of isotones.
Sir, it is a plasma-like fluid, and it will get absorbed easily.
No, actually, the bicarbonate presence actually has a reduced.
We can also.
Yeah. See, when you have bicarbonate, usually the action of anesthesia is better, and the pain during anesthesia is much less. You're saying it is you're doing it under local anesthesia. So when you use bicarbonate-based solution, the pain during injection is much less, and the anesthesia action is better. That's the reason we use. Otherwise, usually what we do is we add normal saline along with bicarbonate solution separately. We add.
Yes, sir.
Such bicarbonate solution we add separately. If single lactate has already a little bit of free mixture. Okay, then why you add hyalase?
It is a dissolution of the collagen.
A better penetration.
To make a plane.
Fine. So, how much other we will add?
How much butter? Sir, 1:1.
Sir, 1 ml of adrenaline.
In
200 ml. 200 ml of.
So what will be the concentration now?
1:2 lakhs, sir.
Fine. So Xylocaine, how much you will add?
Sir, 2%, 30 ml.
Fine. So what is how will you calculate because one of the important thing when you have local anesthesia toxicity. So what is the maximum dose for a Xylocaine? It's one of the most commonly used by a plastic surgeon. What's the maximum concentration?
Plain Xylocaine is given 3 ml per kg. And with adrenaline,
it 3 ml.
5.
3 ml
per kg.
3 ml per kg?
Yes, sir.
3 ml. 3 milligram, man.
mg.
3 milligram per kg.
Sorry, sir. 3 milligram.
3 milligram per kg. Okay.
Yes. And
with adrenaline, 7 mg per kg.
7 mg. Okay. Fine. So that will be the maximum dose. Normally in a Xylocaine 2%, 1 milligram has how many milligram? 1 ml.
1 ml, sir. 1 yeah, achha.
How many milligram it has?
Yes, sir.
Unless you know that, how can you calculate the milligram?
1
ml has how many milligram in the xylocaine? 2%. Unless you know that, you can never make a proper mixture. How will you calculate for? You know these values right. Now, how will you add? One ml is equal to 20 milligram.
20 milligram.
So now, based on that, you have to calculate without how much ml you have to mix and how much you are going to give. Fine.
What
Actually,
is the fourth component?
Hyaluronidase.
No. The fourth part. What is this? You didn't identify this.
This is sir.
Gun.
Yeah.
Ma'am, actually, time is up. Can we go to
Time
the
is out. Next session. This is option D. Yeah.
Yes, sir. It is a case of child with left unilateral complete cleft palate, cleft lip, and with Nagpur's classification CLP-GP 1. Or it can be the CLP-GP3 could also be there. I want to do intraoral examination whether palate is also involved or not. And CLP-GP1A is there because alveolus is it is also involved. And with left nasal deformity. With left nasal deformity.
In Nagpur classification, you need to add furthermore CLP-GP1.
1A.
Then right side.
1A lateral left, 1A left unilateral.
Then complete or incomplete?
Sir, complete, sir. Complete.
Complete. So all these components you need to add if you're telling Nagpur classification. Who devised the Nagpur classification?
Radha Krishnan, Doctor.
No.
Balakrishnan.
Full name? Like, what is it? There are many Balakrishnans. Very senior surgeons are there.
Dr. C. Balakrishnan, sir.
C. Balakrishnan, yeah. Very good. Okay. So, the next question has come. Tell.
How will you assess this case? Sir, I will I will assess this case. I will ask the patient attendant mother, ask the patient mother to whether any drug intake during period of gestation, and also I will rule out other congenital anomaly, and for lip, and I will also do intraoral examination whether palate is also involved or not. Then I will counsel the parents if patient.
Wait. For assessment, we are talking about assessment only. What other things you will do? One is oral, intraoral, you told. Then any other?
Intraoral and
to rule out cardiac anomaly also we have to congenital anomalies like cardiac anomaly.
If you're suspecting, you told you might be suspecting cleft palate also. What else you want to see?
Sir, also I want to do.
Do you want to do any ear assessment?
Yes, sir. Hearing assessment.
Middle ear.
Hearing or something else?
Hearing.
No.
Eustachian tube. Whether eustachian tube is.
You will assess for otitis media.
Otitis media, sir.
Any discharge from the ear or bulging of the ear. So you have to take help of your ENT colleagues, or you do it on
recurrent infection.
Okay. Other panelists, please.
Sir, you can proceed.
Okay, madam. So, like, this child comes to you, like, on maybe second day of birth, the parents come to you with this child. What will be your plan at that time? Like, how will you deal with this situation?
We will, sir, I will explain the patient. I will counsel the patient regarding feeding. Feeding advice will be given. And patient, the child to be placed in upright position in mother's lap. The feeding is given in the posterior aspect of tongue, so that less chance of aspiration will be there. And also the frequent meal with small frequent meal we will advise.
Sorry to interrupt. At this moment, we are looking at the lip only. So, assuming that child has only cleft lip, then what kind of feeding advice you will suggest? Assuming that lip, we don't know about the palate. So, all burping and upright and all is related if there is a cleft palate. Okay, for lip, what advice you want to give?
So we will like to go for taping of the lip also, sir.
If the width is more than nasoalveolar molding, we will do the.
Very good. You will go for taping of the lip. That is
taping
one.
Of the lip.
Number two, feeding advice you give. What other advice you will give?
I will explain the attendant regarding the number of operations it will require.
Okay.
Yes, sir.
How many operations?
If palate, whether I will assess after examining the palate also, and for at the 5 month to 6 month cleft lip, I want to operate the cleft lip, and at the age of 9 months to 1 year I want to operate the cleft palate, and at the time of eruption of lateral incisor at the around age of 7 to 8 years, I will like to go for alveolar bone grafting, and then secondary rhinoplasty at the adult when he patient attains 18 around age.
Okay, good.
Along with maxillary.
Right, good. So you decide to do a lip repair around 5 to 6 months of age. Why not earlier?
Because anesthetic complication will be there, sir.
Sorry?
Anesthesia related complication will be there, sir.
No. Is it necessary that it will suppose a very good anesthetist? Can you not do it? What is the earliest according to textbook? What is the earliest you can do?
Sir,
Rule of 10, sir.
3 months, sir.
3 months. 3 months.
3 months.
Standard is 3 months. Earlier than that is very depends on a lot of other factors. So 3 months. What factors will decide on the operation? Like we do at 5 months, 6 months, or 3 months. What are the things you will take into consideration?
Whether the patient is
age should be more than 10 weeks. The hemoglobin should be more than 10
gram per deciliter.
Weight should be more than 10 pounds.
Okay. So what is this rule known as?
Millard's rule of 10.
Millard's rule of 10. Okay. So you decided for lip repair. Can you tell what are the principles of lip repair?
Sir, in case of lip repair, the vermilion continuity should be maintained. Left, the filtral column should be there. Filtral column should be maintained, and the nose, the alar, the base of columella is also to be maintained, and the white roll.
Okay, you are telling right, but are you aware of some criteria based on which we have this?
Stephenson's criteria.
Very good, very good. Can you tell based on that what are the criteria?
Yes, sir, there are 7 criteria.
Okay. Okay, tell whatever you remember. Tell what are those criteria.
Vermilion. The white roll should be maintained, and filtral column should be everted and
Hmm.
the cupid bow also is to be.
So white roll continuity should be maintained.
White roll continuity, filtral column should be there. Cupid's bow should be
preserved.
Preserved. And nasal ala and nasal LR.
What will happen?
The the three layers, sir. It should be the layers
Continuity of the 3 layers. Then
continuity. Muscle is most
then
important.
what about nose and nostril?
Nostril, sir, the columella should be
nostril. Nostril should be symmetrical.
Symmetrical, sir. Symmetrical.
Nostril should be symmetrical. Nasal floor should be repaired.
Repaired.
Okay. So these are all the criteria. So what repair would you like to do?
I will like to go for Millard's lip rotation advancement. Millard's rotation advancement flap.
Right. So what do you feel is the why do you want to go for Millard? What are the other options available?
Yeah, I can also, sir, go for Sir Randall Tennyson lip repair, sir. Triangular flap.
You can decide whatever you want to take. That is okay. The other option is Randall Tennyson. So why would you like to go for Millard?
Sir, Millard is a cut as you go technique is a qualitative repair, not a geometry. Not. Sir, I want. Sir, if sir.
So we'll just
the tissue
what are the advantages of Millard? The purpose of question is tell me what are the advantages of a Millard repair? Millard
repair, sir, it is a not a it is a cut as you go technique and see the advancement, the lateral
technique number 1. Then number 2.
The
how does the final scar look like?
So final scar, sir. The triangle will not be there in the lower. It will be on the upper near the nose, nasal floor.
Okay.
What are the disadvantages? It is cosmetically better.
Good. What are the disadvantages of Millard?
Disadvantage is that
yes, something.
It is
a subjective technique. Cut as you go, no? Subjective.
Cut as you go.
So if you're
not more experience required.
You need some more experience. Then second is.
And also so if we go beyond the midline, then if we extend it beyond the midline, then it is it will fail.
No, not like that. It will not fail. The scar is straight line. So what happens to the straight line?
Yes, sir.
In plastic surgery, what happens when you put a straight line scar?
Sir, contractions, sir.
Short lip might happen.
Short lip might lip discontinuity.
Not lip discontinuity. Don't mix up. It is contraction of the scar can lead to short lip on that area.
Short lip.
Okay. Then what about the layers which we will repair?
Sir, first I would like to repair the orbicularis oris and muscle and both the orbicularis oris marginalis and peripheralis. And then I would like to repair the mucosal layer and then I would like come to skin.
Correct. So what is the attachment of orbicularis oris in this kind of?
Orbicularis oris will attach at the attachment will be at the nasal nasal lateral element of orbicularis oris will attach to the lateral ala.
Correct. The lateral lip element.
Lateral lip element, and medially it is going to attach with the.
Where else it will attach?
Nasal cell.
You have to make it free, na? You have to know where it is attached. So you have to
sir, cartilage, sir. Cartilage.
LR cartilage you told already. What else? The orbicular oris will attach to LR cartilage. Where else it will attach? On the lateral side. On the maxilla. On the maxilla.
Maxilla.
That is the maxilla, no? Nasal floor, nasal base. Okay. On the medial side, where it will get attached?
On medial side, it will get to the nasal septum, sir, and septal cartilage. Nasal septum and yes, sir, and
columella, premaxilla.
Columella, sir.
And premaxilla. So why is it important to know these attachments?
So at the time of operation, we need to release these attachments, and then we suture both the ends.
Correct. So you have to identify the attachment, release it, and suture it. What about what do you know? What is Nordhoff's point?
Nordhoff's point is at the lateral element where the white roll starts getting thinning and changes its direction.
Very good. And
yes, sir. And also the measurement from commissure, it should be equal to that of the opposite side.
So you told white roll thins out and equidistant from the commissure of the opposite.
Equidistant from the commissure.
So what is the Nordhoff point? What is the ultimate use of the Nordhoff point?
The Nordhoff's point, it should be coincide with the filtral after repair. It should at the upper part, the Cupid's bow.
It will form the.
It should
form the.
It should coincide with the Cupid's bow. Lateral left.
The peak of the Cupid's bow.
Peak of the Cupid's bow.
Left side. Okay, just to coincide with the peak of the Cupid's bow on the left side. Okay, what is the post-operative advice you will do for a patient who has undergone lip repair?
Post-operative advice, sir, for lip repair, sir, the
continue taping of the wound should be there.
And it should not be dirty, sir, with milk and.
It should not be dirty while the child is feeding. Then what kind of diet you will want to give the child initially?
So liquid diet, sir.
Liquid diets. And then?
Sir, yes, sir.
Then change over to semi-solid or solid?
Semi-solid, sir, then we can change over to semi-solid after 2 weeks.
Yeah, whatever your institute protocol, you can tell that. Okay. Any other panelists should like to ask, madam? I think I am asking only.
So you are the master, sir. I think you are the right person to ask, I believe.
Nothing, sir. So then tell me something about Rendell-Tennyson repair. Have you seen that repair?
Rendell-Tennyson lip repair is a lower triangular flap technique, and it is a more geometrical technique, sir, where we are measuring we will make a cut over the medial element, sir, and it will pull down at the level of.
Okay, so we are taking a triangle on the lower part of the lateral lip element.
Yes,
so what is the principle of taking the triangle? What does it do?
Yeah.
What it will do? Have you seen a Rendell-Tennyson repair?
Yes, sir.
Yes. So what does it do? How we decide the size of the triangle?
Sir, we measure the medial element. We measure with the Castrovillo caliper, and from that and from the Nordhoff's point, we mark the lips, the midpoint of columella and the lowest point of Cupid's bow on the lateral element, and at the midpoint of columella and at the midpoint of Cupid's bow, and all we will do marking, and then we from the Nordhoff's point we make an arc of distance.
That's okay. You're telling me the steps. I just want what is the principle? Like how do you decide on the triangle size? The triangle size of the triangle should be equal to the.
The triangle size should be equal to the distance between the from the midpoint of
difference.
The line joining
the normal. The difference between the normal lip and the medial element of the cleft lip. You take the difference whatever is the height difference, that is the
Whatever.
angle that will come
Yes,
from the
sir.
lateral lip element. Okay.
Yes, sir.
What is the name given to that difference? You have to calculate, isn't it? What is it called? The name given to that difference of the filtral column length. Have you heard of drop?
Yes, ma'am.
Drop.
Drop, yes, ma'am. The medial element, sir, ma'am.
Yeah. Sir, please proceed.
Actually, time is up for this. Can we go?
No, let him complete it.
Okay.
Wants to, yeah.
Then I think just one more thing we can discuss is that during anesthesia, what kind of position do you maintain? And
Sir, I would like to place the pillow in between the two shoulder blades and the neck in hyper extended position, so that the eye would coincide with the wall of the ceiling, the back of wall. I should be parallel to the back of wall.
No, it should be slightly extended. You're doing lip only, no? So slightly
Okay, sir.
extended.
Yes, sir.
Palate, you're not doing palate. And what
Yes,
is
sir,
the name of the tube? Specific.
RAE, sir. Ring Elder Elvin tube, sir.
Very good.
South pole facing.
Okay, madam, I think.
Yeah. Next session, Nikita.
Yes, ma'am.
Patient is a case of post-burn contracture over neck with scarring over hypertrophic scarring over the right side of chest with hypopigmented patches extending towards the right shoulder, and it is a type 2.
It's not only on the right side, it's actually in the midline and even little bit extended
Midline,
to the
and
left
even
side
it is
Crossing the midline
yes, sir,
towards the
it is-
left. Parasternal.
I will counsel the regarding the
First, we'll counsel about the procedure, sir. What we are about to do.
counsel. Hello. I will counsel regarding the operative procedure in this patient, and the post-operatively the position should be maintained for a long time. So this the patient should be sound-minded, and he should he will be in for around a week. The position will be hyper-extended, neck extended position, and
We'll ask the patient in post-op period. We'll counsel the patient about the proper neck splintage. We'll give the neck collar for up to 6 months to 1 year until the remodeling of the remodeling is complete.
And also the hypertrophic scar and contracture recurrence, I will explain, sir. And whether also I will ask the patient whether he want to get operated for the contracture and also or want to get operated for the hypopigmented scar.
May I interrupt you, please? Are you aware of any staging system for mentosternal contracture? What stage? Oh, grading, sorry. What grade?
Grade 2 it is, sir.
What is grade 1?
Sir, in grade 1, there is a contracture band, but the movements of the neck are not restricted. In grade 2, there is slight restriction of the neck. And in grade 3, there are severe mentosternal adhesions, which moderately restrict the extension of the neck. And in grade 4, there is severe sternomental adhesion, which prohibit the neck movement, sir.
Is there any more objective classification in terms of whether it is above 90 degrees, less than 90 degrees? Otherwise, it's quite subjective. So in grade 1, there is no contracture. Patient feels tightness. Grade 2 is he can see more than 90 degrees. So his extension is quite good here.
Yes.
So do you think he has come to you for contracture release or something else?
Sir, for hypopigmented patch and the hypertrophic scar around the right side of the neck.
These are the three components that patient can is asked about whether what he wants and counseling.
Yeah. So that is important. What the patient wants, you have to find out. So since and also you would want to know whether this is mature or immature. So the duration since the time this is there is then important. So if it has been there like this static for a long time, it is unlikely it will go into recontracture.
Yes.
So the focus for you is not really on release and maintaining it, but then it is on aesthesis. So is always the graft better, or there are any flaps which can improve the aesthetics?
So which will be better in this case? That's what sir asked. So what are the options and what are the advantages and disadvantages of each one?
So labs we can use this trapezius.
Sir, graft would be graft can be suitable for the neck region, sir.
Okay.
Paras
And for the chest? No, see, the thing is, what are the different, what Sarah is asking is there are different options. So what is your plan? And in case patient is very specific about the aesthetic, then what will be your option? That's what Sarah is asking.
Flaps.
If flaps.
Trapezius smile.
No.
Scapular. Paras.
You have the full armamentarium available with you.
Yeah.
Fully loaded OT. Everything is there.
It can be pedicle, free, whatever thing. So what is the options in this case? If it's a flap.
Micro is also open.
Free.
Okay.
Anterolateral thigh preflap lubricant.
So super thin microvascular.
Dermal, yes. Dermal ear tube.
If it is a regional flap, any regional flap that you can think of?
Scapular, parascapular.
Far away, slightly closer to the neck.
Supraclavicular.
Yeah. Any role for non-flap methods? Any way you can increase the skin, surrounding skin?
Tissue expander.
Yeah, it's a good option in this case. So you can specifically target one area and keep a expansion and then use that. See, that's what as he said, what the patient exactly wants. He wants only for the contracture. As I mentioned, the contracture is not much in this case. It's more of a minimal contracture with more of an unstable scar in the chest wall. So what the patient exactly wants. So he wants only for the neck or the entire thing. So based on it, because in this case, just releasing a little bit of contracture is not going to serve, because for him the much bigger problem will be the thick scar in the chest wall. He might be definitely worried about that.
Yes.
So for that excision, we have to do a good aesthetic cover. So you should have all the possible options in armamentarium 1, 2, 3 with the advantages of each, which you have to explain and you have to plan for everything. So in case you are using a free flap here, which vessel you can choose? There are many options, but still I'm asking which vessel you can choose.
We can choose neck vessels.
Okay.
Neck vessels.
Okay. Others?
Other we can also choose thoracoacromy.
Yeah.
Thoracoacromy.
Yeah. So thoracal upcoming supplies which?
Pectoralis major.
What?
Pectoralis major.
Okay, fine. That can be used. And one more we can use is the internal memory also can be used.
Internal memory.
Just line below it. So these are the options. So you can just have, and an expanded flap will give a better outcome. And a tissue, free flap, the expanded free flap might give because the skin will be much thinner, and also the donor site can be closed primarily. And Sarah was asking, apart from that flap, what other options you can consider? Suppose the patient doesn't want a free flap. What are the other options that can be considered in this case?
Incisional release and STSG cover. Thick STSG cover. And or
Yes.
tissue
Then
expansion.
Next other option.
Also, we can
Other.
the dermabrasion, hypopigmented, both all. Keloid, intralesion.
No. That can reduce things. No, you can use consult for dermal templates in this case. So you use a dermal template on the graph. That also can be considered in these cases or other options. And one more important thing, after all these things, especially when you're using a graph or a dermal template, the post-op scar management is very important.
Yes,
you can massage using a silicone gel sheet and a proper scar massage, and the neck posture should be maintained very specifically in these cases. So there's a specific question as asked, what's the management plan including the leukoderma patches?
Tangentially excise we can, and or we can do dermabrasion, and then we can put thin STSG.
Yeah. Post-operative care and follow-up discussed.
You can ask any procedure for operative session. Time is over, Likita.
Here we can.
Hello, candidates. What is a mutter flap?
Yes, sir.
Pardon, sir?
Mutter flap. Have you ever heard of it? For PVC neck, it can be a flap.
Sir, please pardon your
Mutter flap.
quarter.
Mutter. That is something like cervico-humeral flap.
Okay, sir.
Okay, that can be used. Not in this case, but PVC neck, you can use that flap as a local flap.
Yes, sir.
Panelists can ask any specific operative procedure.
Yeah, madam. I think we discussed flap, tissue expansion, and dermabrasion.
Operative steps of some operative procedure.
Okay.
Otherwise, we can go for documentation.
Yes, madam.
Documentation session.
Yeah.
You can go ahead.
Okay. Likita? Yeah. Srivads?
Yes, ma'am.
Yeah, go ahead.
Yes, ma'am.
How will you document? How will you? What all documentation?
There is in the given picture, ma'am, there is loss of upper lip along with the oral commissures and loss of tip of nose, septal cartilage, bilateral ala, and part of dorsum of nose.
Complete documentation you have to tell, not
A
just
case of is a case of it can be ma'am post assault, post traumatic sharp injury.
Anything else you want to look for? Without examining.
nasal bone fracture or
Intraoral you do not want to examine?
Sir, we would like to examine the intraoral.
Intraoral, I want to look for any oral cavity or palate or any teeth, any
You will
teeth
examine
is
it like any other facial injury with soft tissue and facial fractures.
facial fractures. Yes, sir.
What all you will examine intraorally?
Intraorally, sir. Intraorally, I want to examine the whether any
Sir, look for the any loose dentures. Look for the continuity of the palate.
How will
Hard
you do?
palate.
How will you look for the continuity of the palate?
the anteriorly the palatal shelves should be intact up to the posterior, up to the uvula. And both hard palate and soft palate we will. And also
sir, is
we
there
will
any communication between the wound and the oral cavity?
also whether any contusion or any I want to palpate also for any bony discontinuity for any palatal shelves.
And also palpation of the face to clinically rule out any fracture suspected.
What will that involve? How will you? Palpation means what are you looking at exactly?
To look for bony crepitus, any discontinuity or disfigurement of asymmetry if present, or any swelling around the malar region, or is there or not?
It is mainly a mid-facial injury.
Also, I would like to look for the jaw movements, whether they are
the mouth opening, whether mouth opening is adequate or not. And it is a mid-facial injury. So I will also look for any fracture or zygomatic or maxillary or nasoorbital or orbitoethmoid fracture or
mere naming is not enough. How?
By first of all by clinically inspecting and palpating the fracture segment, whether bony crepes are there or discontinuity on or there or any edema there or eyeball. I will like to see the eyeball, whether eyeball
there is hemorrhagic
hemorrhagic contusion or inophthalmos or diplopia is there or not.
What is the sign to see if there is a Lefort fracture? What sign? What sign you have to elicit to say there is a Lefort fracture? What is maxillary rock? How will you elicit if there is a maxillary rock? So if you stabilize the patient's head with your left hand and then hold the upper alveolus and move, there is no movement. So if there is a Lefort fracture, you will have movement, and depending upon what level the movement is, you can make out Lefort 1,
Yes,
Lefort 2.
Yes, sir.
You're describing about the eyeball. What are the things you look when you examine the eye?
I want to look for any movement or the diplopia or subconjunctival hemorrhage is there or not, periorbital ecchymosis is there or not, the epiphora is there or not, or the vision, whether it is full vision is there or not.
Aspects of vision have to be checked.
Inophthalmos is there. Sir, whether with the visual acuity, I want to go for visual acuity testing assessment, whether
You'll see for visual acuity, the field of vision.
Field of vision,
How do you check for diplopia? Steps of checking diplopia. How do you pick the patient set? Where will you be standing? What distance?
Yes, sir. I will ask the patient to move the eyeball without moving his head, and I will place a finger on at a particular, and then I will check all the extraocular muscle mobility of all the in all the all the quadrants, sir. Vertical, horizontal, all oblique quadrants.
What distance is recommended as you hold your finger?
Sir.
As you hold your finger, what distance is it recommended to be?
6 meter.
You'll hold the finger.
No, sir. 1 meter.
Okay. Madam, is that what the session was about, or is there anything else?
Suppose you
have they mentioned MLC making?
That I want to ask, what in particular MLC, what particular term you will add for this kind of injury?
For documentation.
We will do MLC.
Whether we will do the put the medical legal case number and whether history given by the patient or by the attendant or the
Any
marks.
particular term you would like to do for this kind of injury?
Yes. What steps you will go ahead? Even the stages, everything you have to explain and document, isn't it?
Yes.
So what will you do?
Yes,
so you have to mention about the patient consciousness, alcohol, breath.
Whether patient is
Also, they have mentioned
time of loss of consciousness.
When the patient will come, we'll ask for the MLC of the patient.
Yeah.
And then we'll take the history, whether the history was given by the patient himself or the patient's attendants, that we will document.
Yes.
And what is the mode of injury, whether it is an assault or it is a post trauma due to any other road traffic accident or any other
homicidal or suicidal or post assault or accidental, it is, or self-inflicting, but that is less common. And whether
the patient was oriented at the time of incident or not.
Whether patient is brought by whom, and whether whether he is the relative or anybody else, or and the scar and the any scar marks over the body, so to identify the.
Will you call this injury a simple injury or a grievous injury?
Grievous injury, sir.
What is grievous injury? According
Sir,
to
sir, there is a nose is also nose is also lost, and the facial disfigurement is also there. So that's why this is considered as a grievous injury.
Facial disfigurement along with loss of lip, sir, and nose, that will compound for grievous injury. And if there are any fractures, so that will also go for in the case of grievous injury.
And if any, if a patient is requiring 20 days or more hospital stay, ICU stay, then also it will considered as grievous injury.
Right.
And if any ocular vision loss is there, then also.
Correct.
Loss of one tooth also should be considered as the
Tooth. And also we will rule out other injuries.
Yeah, correct.
So all these things you need to document, and clinical findings, and what to be done for the patient, stages, all those things. So this comes under documentation.
So this in documenting the nasal, loss you just mentioned, you have to mention very specifically. I think as a plastic surgeon, you can't just mention the tip of nose.
Yes.
You can say the tip along with the cartilage, nasal tip, and the ala, and the anterior septum, columella, then philtrum, then the entire lip with the vermilion. So everything should be, because as a subunit you can mention
along with the measurement.
Because the overreach now, there's also without seeing the photo, they should be able to see how is the patient's condition, something like that. Description should be in such a way that they're able to assume, so you can explain all the last units.
Yes, sir.
Yeah. So go to the next one, ma'am.
Yeah. It's over, completed. Any questions from delegates or people can be asked. Otherwise, we'll go to the panelist session. There are no questions in chat box and from delegates. So I request Devi sir to put the analysis and your recommendations or suggestions or additions to PGs and tell
Yes, madam.
something about Plastiquest, what you feel.
Yeah, very good. Actually, very nice presentation by our candidates for today, and Dr. Shivas and Dr. Karthika.
Thank you, sir.
I found your presentation was good. Well, you presented well. You are all confident also, and you answered reasonably well.
Thank you, sir.
What I wanted to say was most of the direct questions you could answer very nicely, but the indirect questions and little twisted questions were little difficult, mostly because you may not have anticipated it. So in actual practice, you need to keep those things in mind. That is some sort of three-dimensional view you have to take. So those kind of things. Then you're answering well, and the thing was just take time to listen to what the examiner is asking. So let him complete, take a moment to think and answer. Because like if you attended yesterday, you don't get time for marks for answering in fast. You get marks for answering it correctly. So always take a moment to think over the question and then answer, and listen to what the examiner has to add. Then you add on your points. That way it carries a better impression. And overall, I felt it was okay. In actual practice, during exams, you will be asked to make some diagrams, like we're discussing about cleft lip and all, you will have to make the diagrams. So these things you have to practice on your own, discuss with your colleagues, and then make it be ready for those things, because it can happen. Many times they will ask you to make a flap marking or draw the landmarks of a flap or something like that, no? And then you have to be prepared for that. That means the alternate things you should be prepared. Regarding Plastiquest, madam, very nice session today, conducted very smoothly also. And I think all the participants who are missing out, those team members, they should be told specifically that they will be losing some marks because of that question session. Those who don't ask questions, they will be losing marks. So they may be conveyed that. So no one misses out on their questions.
Not only missing the questions, they absence also makes some loss of marks.
Yeah, right, madam.
It be disciplined way, and they have to be present for all sessions.
They should be present.
This
It's
is
good actually.
specifically mentioned, sir, and this is for the benefit of them only, because we are covering almost all cases, all spotters, all X-rays, and operative sessions, everything. So in a very short period.
Correct,
So
madam.
their presence should be must.
So as I was telling Lakshmi madam also, the students are very lucky to have this session available. And like you have an opportunity to interact with all the experts, different faculty. So today oncosurgery, we had Binay sir, we had Selva sir, and Sundar sir, all senior people and all experts. So even for the participants, it is the right time to ask some few questions like we're discussing and all. So just ask your small doubts and all here. And overall, it was a satisfactory session, madam. And that's all from my side at the moment.
Thanks a lot, sir. The same response is there from all the people. And with this, all your support only, I could do some justice in conducting this program. And I think all of you give the same support. Yeah.
Madam, thank you very much.
Sir, please stay. 3 more people are there. They will tell them 5 minutes. Dr. Sundar, Dr. Vinay, sir.
Yes, madam. Yes, madam.
Sir, please put your analysis. And,
so my analysis is that it is a very, very good attempt, and since there are so many people and it is a very interactive session. So this is actually that opens up our mind to a particular problem. We can discuss it in a much better way and in a much practical way. And it's going to be very useful for not only the students, but the panelists and the rest of the people as well, because there's so many things which are discussed and there's so much of exchange of knowledge as well. So it's a very, very good attempt, I would say. Very nice.
Thank you, sir. Thank you very much for sparing your valuable time.
No, it's our pleasure.
Sundar sir.
Yeah, it was nice, Srivatsa and Kartike.
Thank
Very
you, sir.
confident and whatever you said came through well. I think in the main exam, you should present enough in your institute so that you actually don't hold the paper in front of you as you present. Because later in practice also, you are going to ask the questions from whatever you have learned and what is in the mind. There are about 25, maybe 30 scenarios in plastic surgery in MCH exam. So it should be like it should be anytime you are woken up, you should be able to take the history. So practice without the paper, because today you are going through the slides back and forth. And incisions have to be marked on the patient. And pattern has to be done of the defect. You show in the exam that this is the pattern. Then after resection, this is the defect. And then keep plan 1, plan 2, plan 3. Because today's session, your radial pattern, that flap probably wouldn't have survived because it was not over the radial artery. Some senior examiners might stop at that point and say your plan 1 is not going to work, show me plan 2. So you should be ready with the second plan. Or it might be that for the discussion's sake, you're told there is no microscope. So what are you going to do? So you need to also keep for oral CA plan of BPPMNC also. You will have about 45 minutes as a long case, perhaps. So it's enough time to have 2-3 plans also. And it was a wonderful session, madam. Earlier in large cities, you are roaming around to different hospitals to catch hold of the senior teacher and present to them, like in Mumbai, Bangalore, you go from one hospital to another. But here you have at the comfort of your home, people from all around India coming and teaching you. So it is a wonderful opportunity to learn. The questions by other teams, I felt they are probably asking difficult questions to the presenting team so that they can score more points. But like was already said today, it doesn't serve the purpose because some things I think panelists also didn't know. So it's not fair on the presenting team that they are asked questions like that. I think it is linked to the marks. That's why in the desire to win, they are asking like that. But that doesn't serve the purpose.
With the discretion of panelists, next time we will just disqualify the question and we'll ask them to put another question, sir, if they ask like that.
It's out of syllabus question.
Out of syllabus question.
Yeah. Okay, thank you.
Okay. In future sessions, they will try to put the correct questions, because even last session, panelists told the same thing. So all teams try to understand what is required. You need to ask. Okay. So not beyond the scope and not the things. And the real facts you have put frankly, sir. PGs will correct that, and they'll make the proper surface marking when they plan the flap, the artery, vein, and the pattern they have to cut and show. So these are the scoring marks you will have. The judges, I told them, actually, I told the PGs also. So how exactly you have to do. So that in those components have marks, specific marks. So the judges are taking care of those things. So rest of the PG teams try to concentrate on them. Thank you, sir. Thank you very much. Selva.
Yeah, good evening
Selva
all.
Sitaram.
So yeah, man, first of all, thanks for the opportunity to be a panelist in this forum. And regarding the presentation today, they presented really well. I think even the way they presented, all formatted very well, and they were very bold in answering. Few things I like to mention is that each time you